That was so impressive. And I applaud everything you've done in the past 30 years, bringing together scientists and clinicians and families. It's a very important role you've played in the field of leukodystrophies. I want to briefly read a statement in light of recent events in Europe that the scientific committee expressed concern about. The European Leukodystrophy Association International Scientific Advisory Board wishes to express its concern and sympathy for people and families affected by leukodystrophy and the war in Ukraine. We understand the great difficulty of taking care of children with rare diseases, especially without access to proper hospital care or medicines. Our board members will endeavor to provide direct medical support to refugees, as well as hospitals and healthcare providers in the region that can benefit from specialist medical advice on care of leukodystrophy patients. This is a time of empathy and unity for all people and families affected by leukodystrophy. So I think this is in the spirit, Guy, of everything you've also done in the past 30 years, and expresses not just the opportunities, but also the challenges ahead in the coming days.
Caroline.
Caroline.
Oui. Bonjour Caroline.
Good afternoon, Caroline. You have the floor. If you would please like to introduce the various speakers. Good afternoon. I don't know how many people have logged in, over 100. But if I understand correctly, we have a lot of French families. We have a lot of families from other European countries as well. So today, we are going to try and discuss a number of advances, the progress that has been made. We'll also discuss more basic things. I'll have a quick presentation, in particular, on the need to screen patients. But let's start with a presentation by Steven Kemp from the Netherlands. He's going to discuss a Dutch pilot project on neonatal screening. This is a pilot study currently underway in the Netherlands. Steven, you have the floor.
Thank you, Caroline. Let me share my screen. Can you see my screen? Yeah, actually, thank you for the introduction, Caroline. I am presenting the results of the Dutch newborn screening pilot because it's already finished, and so it's not underway anymore. So it's finished, and so we have all the numbers and all the data. So
we do not see your screen, Stefan, for now.
That's interesting. I see it here. Wait a minute. Sorry. You see it now?
Thank you.
Sorry. So as I said, so we have all the numbers and all the figures. So I would like, for the first time internationally, show you the results of the pilot screen for newborn screening for ALD in the Netherlands. But I would like to start with celebrating the existence of ELA for 30 years. And Guy already, I mean, he said it perfectly what ELA is meant for leukodystrophies and for families, and but also for research. I dare to say that without the support of ELA, the Dutch ALD research group may not have been there anymore a long time ago. So this celebrates the success of ELA, and So for 30 years of excellent care and support and awareness and funding research. Okay, let me now start with the presentation. So my disclosures, we receive funding from Strong Biotherapeutics, and I'm a consultant for Strong Biotherapeutics. And this project is funded by the Dutch Ministry of Health and Sport. So the topic is ALD, adrenal leukodystrophy, which is a monogenic disease. It means that there's only one gene that's causative for this disease. And all patients, when they're born, have a mutation or a pathogenic variant, which we call it nowadays, in the ABCD1 gene. And all patients have elevated levels of very long chain fatty acids. So we can diagnose the disease at birth, but we cannot predict the clinical outcome of individual patients, and that's shown on this slide. So if we look at the age of 10 years as a cutoff, before the age of 10 years, 50% of male patients will develop adrenal insufficiency, which is can be a life-threatening disease, and it's often discovered not in the beginning, only sometimes after boys enter in the hospital. Also, one out of 3 boys will develop cerebral or brain lesions before the age of 10 years. This is a rapidly progressive form of the disease, and it can be cured by a bone marrow transplant, but it is only effective in the early stages of the disease. And to illustrate that, patients that are diagnosed on the basis of neurological symptoms are already too advanced for gene therapy or for bone marrow transplants. So we need to identify these children earlier. And in the adult, when patients reach adulthood, all males and at least 80% of females will develop a slowly progressive spinal cord disease. And for that, there is no treatment. But you will hear 2 presentations later on that are focusing on this form of the disease. So just a small 2 slides on the genetics and the biochemistry of ALD. So the disease is caused by a variant in a mutation, let's call it a mutation, that's easier, in the ABCD1 gene. And this gene encodes for a protein, the ABCD1 protein, and the ABCD1 protein is located in this little organelle in the cell, which is referred to as the peroxisome, and it functions there as a door. It's as a gatekeeper for these very long chain fatty acids to enter this organelle where they are broken down. And when there's a mutation, the fatty acids cannot enter the peroxisome, they're not broken down, and there's storage of these very long chain fatty acids, and that causes the disease. Already in 2004, Hugo Moser at a newborn screening meeting in the United States said that ALD newborn screening would save life. Everybody agreed, but at that time it was not possible to diagnose babies at birth, because the very long chain fatty acids we knew already, but you cannot use those in newborn screening. That takes too much time. So the group in Baltimore set out to identify what we call a biomarker, and they identified C26 lysophosphatidylcholine, or C26 lyso-PC, that is elevated in blood spots from ALD patients. So at that time, it was possible to screen newborns for the disease, but that didn't mean that automatically ALD would enter newborn screening. For that, it took another 6 years, and that with a phenomenal role of Elisa Seeger, who played in this bringing this to life, this newborn screening. Her son, Aidan Seeger, he was diagnosed with ALD, but at the moment that he had already neurological symptoms. So he could not receive a bone marrow transplant anymore. And Elisa found out that it would have been possible to diagnose babies at birth. And she motivated people in the state of New York to add ALD to the newborn screening program in New York State. And at the end of 2013, New York State was the first place on this planet to initiate ALD newborn screening. And so this is the map of the United States, but it can also be the map of the world, because only this little green dot over here was where newborns would be were screened for ALD. So, and if we now jump to 2022, we can see that over 27 states in the United States are screening for ALD. And last week, Virginia was the 28th state that started newborn screening, and it's expected that more states are starting. Then now back to, so at this moment, over 75% of newborns in the United States are screened for ALD. So now I want to move back to the Netherlands. Also in 2013, my colleague Mark Engelen and we became aware that the Dutch Health Council had plans to expand the newborn screening program in the Netherlands. And we got a chance, or we took the chance to nominate ALD. And in 2015, the Dutch Health Council published a recommendation to the Minister of Health. And with that, the plan was to add 14 new diseases to the Dutch newborn screening program. And this is a list of the diseases that are in the newborn screening program. And this group on the right are diseases that have been added already with alpha and beta thalassemia in 2017. And and every year additional diseases are added. You cannot add them all at once, because then you would derail the system. So this is a very very delicate process. So if every year you add 1 or 2 diseases, then it will keep running. But the decision that was made by the Dutch Health Council is an interesting one, and I would like to explain it to you. And then if we go to 1968, Wilson and Younger for the World Health Organization set out criteria for diseases that they need to fulfill in order to be eligible for newborn screening. And one of the most important criteria on that list is that early diagnosis must be directly beneficial to the neonate. So there must be a treatment. And this is translated from the report from the Dutch Health Council, in which the Dutch Health Council said that screening for ALD is only useful in male newborns, because the symptoms in women usually arise later and cannot be treated, because women do not develop adrenal insufficiency, and they almost never develop brain disease. So therefore, the committee recommends to only screen male newborns for ALD in the newborn screening program. And that's in contrast with the United States, where all newborns are screened. And there are reasons to do that. And for the sake of time, I cannot go into that. But we have a difference. So in the United States, it's boys and girls. And in the Netherlands, it would be only boys. Gender-specific screening did not and still does not exist anywhere on the planet for any disease in any newborn screening program. So we did not have an example available at that time. And that's required a pilot study. And this is referred to as a scan study, screening for ALD in the Netherlands, with the logo here at the bottom. So if we look at the Netherlands, but that from a newborn screening perspective, the 12 provinces initiated and the islands in the Caribbean that are part of the Kingdom of the Netherlands are divided in 5 regions, newborn screening regions. And all these regions here in the different colors have their own newborn screening laboratory. And the scan study, which is a pilot, in which we had to develop and test a boys-only algorithm, which I will go into in the next slides, would include 2 screening regions, indicated the one in pink, or in purple, and in orange. So these are 4 provinces, and the pilot would last for 1 year. And in 1 year, in these 4 regions, about 70,000 newborns would be born and screened for ALD. So the task and the challenge that we were faced with is to design, develop, and validate in a live setting a screening algorithm that would include a test, what we call a tier, that identifies males by using only dry blood spots. And on top of that, does not identify unwanted or untreatable diseases. And if you think of an X-linked disease, you can think of Klinefelter syndrome, Turner syndrome, but also the C26 lysis PC is not specific for ALD. Other paroxysmal diseases like Zellweger and others are can be diagnosed with elevated C26 lyso-Pc, and even Aicardi-Couture's syndrome. Some patients have elevated C26 lyso-Pc. And we only had this 3.2 millimeter blood spot available. Okay, we had 3 of them. So what we eventually came up with, it was a relatively simple method to identify, in which you can separate males from females, and that's because males only have 1 X chromosome and females have 2 X chromosomes. So we call this the X counter. And the interesting thing is that for example, on chromosome 3, there's a little piece of DNA, and that little piece of DNA is also present on the X chromosome. So you have a ratio of 2 chromosome 3 and 1 X chromosome, 2 to 1. And in women or in females, that's 1 to 1. And you can visualize that by genetic testing. And then you will see this 2 to 1 ratio and this 1 to 1 ratio. Of course, this test can fail. And the nice thing about this kit that we use is that it has 3 of these little pieces of DNA. So in males, you would see 3 times the same 2 to 1 ratio. In females, you would see 3 times the 1 to 1 ratio. This is the algorithm that is used, for example, in New York State, which is a 4-tier program. And we placed the X counter and the second tier. So the first tier is done in the newborn screening labs, and then the second tier is done as the second. Well, I'll go into that later. So this is the Dutch 4-tier program, and to make it a little bit more logistically challenging is that the first tier, as I just mentioned, is done in the newborn screening labs, and 2 would participate in the newborn screening program, and then the subsequent steps are done in different laboratory or diagnostic laboratories, and all this has to be finished within 35 days after the blood spot is taken from the baby. It's a pilot, so parents need to give informed consent for their participation, and of course we give a lot of information. So there is a focus on boys only screening, but of course if we want to test this whole algorithm, we want parents of girls to also give consent. So the parents of girls are requested if they would like to participate in the pilot. We started January 1st last year, and we screened until boys that were born on the 31st of December. So I said information is very important. So we also developed a brochure in English, in Polish, in Turkish, and in Arabic, and of course in Dutch. That is handed out at several occasions in the before newborn screening is initiated. We also developed a website with a lot of information. Okay, so now to the pilot. In the 1 year that we did the pilot run, 72,397 boys or newborns were born and offered newborn screening. Out of this, 1,171 parents declined newborn screening, and that's because some declined newborn screening overall, and some declined participation in the ALD pilot. And if we look at this 1,171, we see that it is 2/3 of parents with a girl and 1/3 of parents with a boy declined participation. The participation in newborn screening analysis is very high. The overall participation is over 99%. These are the numbers from 2020. And if we look at the ALD newborn screening pilot, almost 90% of male newborns were screened for ALD in the pilot. So 71,208 blood spots over the year, throughout the year, so not all at once, but throughout the year, entered the algorithm. And so first at tier 1 in the newborn screening labs. If we look at the concentrations of the C26 lyso-Pc, we see a nice distribution. And this is what you would expect. And this red line indicates the cutoff. So if the concentration of the C26 lyso-Pc was 0.32 or higher, we would have a screen positive. And if we zoom into this, we see that these are all the numbers, all the blood spot cards that had a higher concentration. And throughout the year, there were 507 cards that went to tier 2. the X counter. And the X counter, as I explained, we counted the number of X chromosomes, so 2 for girls and 1 for boys. And if there was only 1 X chromosome, this card would go to the 3rd tier. And throughout the year, we had 249 boys that had elevated levels of C26-lyso-Pc, 1X, and then they went to tier 3. And now you may think, hey, this looks like the tier 1. Tier 3 basically does the same as tier 1, but it does it much more specific. Before we started, we validated tier 3 in the laboratory, and we had random samples from newborns. We measured C26-lyso-Pc. We had some blood spot cards that we could retrieve from the repository, and we also received some. I hear somebody talking. We also received some cards from New York State, from Joe Orsini, to help in validating the method. So this we use for the setting our cutoffs. And this is the samples that all went to tier 3 throughout the year. And you see that it really resembles validation data. So this is the cutoff, 0.15. We had 20 samples that were 20 cards that were over the cutoff, and those went to the tier 4. And these are the results from the 20 boys that went throughout the whole program. And so they're referred to XY01 to XY20. In 16 cases, we did not see any variation in the ABCD1 gene. And in 4 cases, we found either a pathogenic or a likely pathogenic variant. And these boys were referred to the pediatric neurologists. So this is the Dutch neonatal screening program. It's a very complicated system, but it works really well. And so these 4 boys, let me zoom into that. The medical advisor or medical consultant of the program received a notification that there was a screen positive result that needs referral. So, and we set up we were really proud of the way how we set it up, because it is really family and patient friendly. So what we do is that as soon as there's a screen positive result from the ABCD1 screening, the medical advisor already contacts the Department of Pediatric Neurology at the Amsterdam UMC. And at that moment, already a schedule for the family is generated for the next day. Then the medical advisor contacts the family physician. Then the family physician contacts the family, and we never do that on a Friday, because we don't want Dr. Google, we don't want these families to start searching the internet. So last year, the four families all received a notification on Tuesday, and on Wednesday they already visit the Department of Pediatric Neurology. So within 24 hours, they had an appointment with the specialist. So now we are at this point here. We had a screen positive result. The family visits the pediatric neurologist. A blood sample is taken, of course, because you want to know that you have the right baby in front of you. That there's no mix-up. So then the testing of the lyso-Pc and the mutation is done again, and then when the results are in, the family comes back to the hospital. And they start in the first they visit the pediatric endocrinologist. He takes a blood sample to test the adrenal function, because that is the earliest symptom that can occur, and that can already occur after several months of age. Then the family visits the clinical geneticist to make a family tree to see if there are other members at risk or who need to be screened. And then they see the pediatric neurologist. And this continues every 6 months until the age of 24 months or 30 months. And then the boy would receive his first MRI. And this continues until the age of 12, and then every year the boy would receive an MRI, and until treatment is needed. So I said that we had to finish this all in 35 days, and so I can show you the results. That in all cases we only took 3 weeks, less than 35 days to complete the whole algorithm. And that brings me to my final slides, the conclusions and the considerations. So we developed and validated an algorithm that enables the identification of male newborns with ALD by only using a dried blood spot. And the algorithm complies to the Health Council's recommendation to only screen boys for ALD. We screened 71,000 newborns, of which we had 36,000 males, and we identified 4 boys with ALD. So in the pilot, the birth prevalence of ALD is 1 boy with ALD out of 9,000 male newborns screened, which is higher than we would have expected. And of course, this is still a small number. So the future will tell us if this number remains or if it becomes a little lower. So now what we're doing now is write the final report, which we have to send to the Minister of Health, and then there will be a go or no-go decision, and then we will move forward to nationwide screening in the Netherlands, and that's planned either for next year or the year after. But of course, we want to have this as soon as possible. And then there's a challenge because I'm speaking about the Netherlands, but in contrast to the United States, in Europe, we don't have a list of diseases that fulfill the criteria for newborn screening. So there's little agreement in Europe which disorders should be screened for newborn screening programs. And also among countries, some countries only screen for 1 disease, and that's often PKU, and other screens for more than 30 conditions, like Germany and soon the Netherlands, and I think Italy also screens for a lot. So different countries, if I showed for the United States, for the Netherlands, make different ethical considerations. And so now we have this algorithm that could be taken over by the countries, and depending on the ethical consideration they make, either for screening boys and girls or only boys, they can pick and choose one of the two algorithms. And of course, there are other diseases that are located in the X chromosome, and maybe in that case also only boys develop disease and should be screened. And then of course the X counter can also be used in that for those diseases. And this is my final slide with all the people who are participated in this big program. And at the end of the session, I'm open for questions. And I think I need to stop sharing now.
Merci beaucoup, Stéphane. Je pense que
Thank you very much, Stéphane. I think we'll take the questions at the end of the session because we're already running late. I would like to then give the floor to do you hear me? I will give the floor to Florian Eichler, who is a neurologist. You all know him, and he has spoken already. And I am very much in support of everything that he said on behalf of the scientific board and ELA regarding patients and the whole Ukrainian population, but especially children suffering from leukodystrophies, and for them, obviously, the situation is even more difficult because of the current events. Florian is a doctor, a neurologist, and a researcher in Boston, and he's going to tell us about the various clinical trials that have been organized for adults, women and men alike, suffering from adrenomyeloneuropathy. Florian, you have the floor.
Thank you, Caroline. So it was a pleasure to be with this community. You know, although not in person, we still come together over Zoom and share in the desire to make progress for patients with leukodystrophies, and here ALD in particular. So I will be speaking briefly about upcoming trials for women with ALD and men with AMN, and provide the rationale and some of the biology that has led to these planned trials. But all of these will be trials that are still in the works. And I hope it provides an insight into what to expect in the coming years. Important part of this is to mention my disclosures here, as I'm involved in many trials and PI of various trials, and also consult for various companies, and importantly also founder of Swan Biotherapeutics. So it's important to understand this, and I'm always much aware of this and trying to present a balanced view without self-interest, but please take all this into account. So you already heard briefly about X-linked adrenal leukodystrophy in Stefan's beautiful lecture. Just to point out again that this is a single gene disorder due to mutations in ABCD1 that leads to elevations in very long chain fatty acids and affects predominantly in adults two tracts. It is the cortical spinal tract that brings motor information down from the brain through the spinal cord within the upper motor neuron tract. And then the other tract that's affected is the dorsal column, which brings sensory information from the periphery through the spinal cord, particularly the back of the spinal cord, up into the brainstem, thalamus, and brain. And these are the two tracts that are mostly affected in men with adrenal myeloneuropathy and women with ALD. To briefly outline the disease course in ALD, you are born with the gene defect. You have elevations in very long chain fatty acids. Stefan Kemp mentioned all the wonderful efforts to make use of that newborn screening to help identify patients early. Between the ages of 4 and 10, there's a high risk period for cerebral ALD. If that doesn't happen, you usually go into adulthood. And the predominant form of the disease is a spinal cord disease called adrenomyeloneuropathy. There's still risk of cerebral ALD occurring in men with ALD, but the incidence is much lower than in childhood. Importantly, we've come to realize over the past few years that women are similarly affected by ALD. And we use now the term female ALD. This is actually not correct. We don't use the term AMN because we don't see adrenal dysfunction in women. We see the myelopathy, we see the neuropathy, but we do not see adrenal dysfunction. But it is very important to note that it's a big population within the adult ALD community, and it deserves our attention and has a different pathology here between the brain disease shown in the bottom and the top being what you see in the myelopathy affecting the spinal cord. Just to point out that in our clinic at Mass General, we see many adults with XALD and equal numbers of women and men. And the gait problems, balance problems are very similar, as are sensory complaints, pain complaints. But note here that in women, often sensory disturbances and pain are more common than in men. Whereas in men, often there is more spastic gait and hyperreflexia, but both of these are common in both genders. Some of the pioneering work in this area has been done by the group in Amsterdam that first described symptoms in women with ALD and pointed out the importance here of the spinal cord disease called myelopathy, as well as the peripheral nerve disease called neuropathy, in contributing to gait, balance problems, and bowel and bladder symptoms. I think in the coming years, we're going to see much more differentiation and study of the various sensory complaints in adults with ALD, and understand that pain and leg discomfort have multiple causes, multiple etiologies, ranging from neuropathy to vascular insufficiency to spasticity and restless leg syndrome. And this is clearly posing some challenges, but also opportunities in terms of more targeted, tailored, precise treatment that will make the lives of adults with ALD easier. Just to point out what a neuropathy is, this is something that affects the peripheral nerve, and this peripheral nerve originates here, either in the dorsal root ganglia or in the ventral root coming from the spinal cord, goes out into the periphery, but also brings back information from the periphery on position of joints, of muscles, and brings information back to the spinal cord. So motor information flowing out of the peripheral nerve to the periphery, and sensory information coming back in. And important, this peripheral nerve mediates position sense, discriminative touch, and pain, and as such is very important also to balance and coordination. Speaking of balance and coordination, this again is the result of many functions of the cortical spinal tract, bringing motor information down from the brain, and the dorsal column bringing sensory information up from the periphery into the brain. So these long tracts are really the target of treatment as they are affected in adults with ALD, and they affect everything from gait and balance to bowel and bladder function. I thought it's important to point out that when we talk about treatments, we're not talking about treatments that universally apply to all stages of life and all stages of disease. This is in brief how XALD affects boys and men across a lifetime. You have pre-symptomatic phases when children are developing completely normally, then 30-40% of boys are affected by brain disease. If that doesn't happen, they go on to adulthood, and focus of our talk today, adrenal myeloneuropathy, as well as the possible occurrence of cerebral ALD in adulthood. In women equally, there are different stages of life and stages of disease. There's a pre-symptomatic phase. There's a lot of considerations around future planning when you know about your gene defect due to family screening or otherwise. And then as you face adulthood, often myelopathy symptoms arising from the spinal cord disease come about, as well as movement disorders that are becoming an increasing focus of our attention. What steps to target along the disease pathway? And I want to shout out to many of the basic scientists who over the years have helped point out that beyond the gene defect alone, there are various steps, whether it's elevations in very long chain fatty acids, or it's reactive oxygen species, oxidative stress that's arising, as well as mitochondrial depletion, leading all to axonal degeneration. And these various steps can be targeted and give rise to opportunities to obtain treatment. So I will briefly outline some of these drugs that are now in trials or about to be in trials, and then spend some time on gene therapy. So briefly to point out the efforts around pioglitazone and leriglitazone's mechanism of action, and the work that has been happening in collaboration with company called Minerix, and this really is work that has taken a village and many different collaborators to work together. And turns out that the PPAR gamma activation due to this drug could have multiple beneficial effects impacting inflammation, oxidative stress, but also then subsequent neuronal survival and potential remyelination. Many of these things have also been shown to be important for possible conversion to cerebral ALD, and it's possible that the blood-brain barrier could benefit from leriglitazone and help prevent future conversion or progression of cerebral ALD. These are many things that have been shown in vitro to be of importance, and various model systems have been supportive of this drug impacting neuroinflammation and microglial activation. The key question is, how can this translate to humans and be brought forward in trials? And just to point out that there has been tremendous progress in a multi-center worldwide trial led by many investigators that are also part of ELA. Importantly, the primary endpoint of this trial was not met in the overall population, but there were some hopeful signs that body sway and balance may be impacted. Importantly, there was some reduction of cerebral lesion progression in a small number of patients that is now leading us to examine the cerebral ALD population more closely. It would be a huge benefit to the community if we found a drug and found a way to impact cerebral ALD and its conversion. So currently, there are various different steps and upcoming studies with leriglitazone. There's a marketing authorization application filing in the European Union by mid-2022. There are ongoing discussions with FDA on what path to pursue. There might be complementary studies in AMN men, considerations whether those should include cerebral involvement or not. There's also work happening in the pediatric populations, and also studies in women that are in preparation. Switching gears to another company that is Poxel, that is pursuing two different compounds, that one being an isomer of pioglitazone, and the other a direct activator of AMP kinase. And both of these have shown preclinical proof of concept benefit. And again, the question arises, how can these drugs be safely and efficaciously brought forward to humans? There's an open IND in ALD with the deuterium stabilized single isomer pioglitazone called PXL065, and an open IND in ALD with the AMP kinase. Just to briefly point out, here's some of the proof of concept studies in mice and cells that have been led to the foundation of some of this work. So obviously, beyond improving very long chain fatty acids, there's here the hope that some of the nerve health will be impacted by these approaches, and the trials will commence with small pilot studies that are going to see whether very long chain fatty acids that are thought to here be an important part of how this drug mechanism may impact nerve health can be impacted, and looking at novel biomarkers such as neurofilament light chain, which is a marker of axonal and neuronal health. And if these small pilots are successful, both in Europe as well as in the US, one of these will then be carried forward, as I understand it, to move into potential phase 2 and 3 pivotal trials. Also, a brief shout out here to the approach at looking at thyromimetics. These are drugs that target thyroid hormone receptors and have been advanced by Tom Scanlon in a company called Autobahn. They have arrived at nice proof of concept studies in mice where they can lower very long chain fatty acids, similar to prior compounds with sorbitol. And if these very long chain fatty acid decreases can further translate into improved nerve health, that might be another path forward for this drug coming to humans. Here, the regulatory path forward and work on IND is still in process. Switching gears here now to approaches to gene therapy, I want to just briefly point out that there are two different approaches to gene therapy, one being in vivo gene therapy, the other ex vivo gene therapy. In vivo gene therapy is the direct administration of the viral vector carrying healthy transgene into the target organ. Ex vivo gene therapy is different. This is has to transfect cells that are taken out of the body and transfected outside of the body, such as bone marrow cells. And then these cells with the corrected gene are then returned back to the patient. So you probably know of the ex vivo gene therapy based on the work by Bluebird Bio that also Guy Alva mentioned earlier. And this has certainly provided a proof of concept that we can perform gene addition in critical cells of the bone marrow and deliver them safely to boys with cerebral ALD. And I support all the concerns that Guy Alva mentioned earlier. We want to make sure that this scientific progress is not stalled, and there are paths forward that be made available to children and family affected. However, the focus of today's talk is upon adults, and in adults, we are focused on in vivo gene therapy, which is usually AAV mediated. It's a different kind of virus, an adeno-associated virus that has been used in many studies for over the past 20 years. And you can see the number of trials targeting various different tissues in which this class of medicine has been used. Importantly, there has been drug approval for spinal muscular atrophy based on AAV9-based gene therapy, as well as for a retinal disease using AAV2 gene therapy. So building on this success, a few years ago, we decided to similarly investigate AAV9 based on the results coming out of spinal muscular atrophy field that showed that boys, that children affected by spinal muscular atrophy had a tremendous benefit from receiving AAV9 directed gene therapy. Why look at spinal muscular atrophy? Well, it turns out that the lower motor neuron affected in this disease is right adjacent to the structures affected in AMN, namely the corticospinal tract and the dorsal columns. So we decided to package a healthy copy of the ABCD1 gene into an AAV9 vector driven by a chicken beta actin promoter. And we were able to show in cell culture that this construct was able to localize 2 peroxisomes and lower very long chain fatty acids, and in mice was similarly able to get into the cell types critical to improve the disease of adrenomyeloneuropathy. So this was an important proof of concept. We went on to develop an intrathecal osmotic pump of AAV9 that we showed delivered very nicely to the spinal cord, lumbar, thoracic, and cervical regions. It was far more efficient than delivering the gene with bone marrow cells. And this has given rise to an approach of intrathecal administration that is now being advanced to humans. Just to briefly mention what intrathecal administration means. Intrathecal describes the space between the thin layers that cover the brain and the spinal cord. This is the space that contains the cerebral spinal fluid. And similar to when you do a lumbar puncture, you can inject into this space and administer treatments such as AAV9 gene therapy. So this is being currently advanced by a company called Swan Bio, and the expectation is that the study will be initiated in the second half of 2022 of this year. The aim is to assess the safety, maximum tolerable dose in a small initial group of patients. This will be a single administration, and there will over time be different study groups looking at dose escalation. Initially, a low dose group will be treated, then a high dose group, and then the maximum tolerated dose will be selected for future studies. So this will be a controlled study that currently has an open IND in the US. So treatments and the trial will first proceed in the US, but efforts are underway to also work through the regulatory requirements in Europe to also open studies and this trial in Europe. So just briefly to mention how this will be administered as an intrathecal infusion over several hours, and the patients can and should ambulate during the infusion. Switching gears in my last section here on new outcomes to target in adults with XALD, are there ways to recognize that there are many different kinds of causes to leg discomfort that could lead to new trials and new approaches? And to just point out briefly that restless leg syndrome, in our experience, plays a big role in adults with ALD and can contribute here to not just the discomfort in the legs, but also poor sleep that is then impacting a daily performance of gait and balance. So just briefly, restless leg is the uncontrollable urge to move legs, the uncomfortable sensation that comes along with this usually happens in the evening when sitting or lying down, and moving relieves this unpleasant feeling temporarily. You can see here the kinds of restless leg movements that occur, and we see quite frequently in adults with ALD. So we conducted a first study on restless leg syndrome, both in men and women, and we found that the patients who had more signs of myelopathy and more symptoms were more commonly positive for restless leg syndrome. We also found that more women were affected by restless leg, about 37, for around 40% compared to men, about 20% that had restless leg. And so this has now led us to undertake a first trial together with the group in Amsterdam, led by Mark Engelen, where we will be examining the impact of treating restless leg syndrome with a dopaminergic drug called pramipexole, and examining in a placebo-controlled crossover whether the improvement in restless leg syndrome and the improvement in sleep will impact daily performance, both of gait and balance, and importantly, also sleep as studied by sleep studies. Importantly, this is a study supported by ELA International and will be using the LucaConnect platform. Lastly, I have to mention that all of these drug trials come with also safety issues. One has to consider with, for each patient possible side effects to the drugs that are being used, whether these are small molecules where we've seen that weight gain and edema can impact quality of life as well. Ex vivo gene therapy employed in boys clearly has side effects during the chemotherapy, and more recently some concerns around myelodysplastic syndrome have arisen. We think that similarly for in vivo gene therapy, there will be immune modulation needed in order to safely combat any inflammation that might arise. But we are confident that with 20 years of experience of AAV gene therapy, this can be done successfully. So it is a hopeful time for drug development in adults with XALD. New technologies, biomarkers are emerging, targeted gene addition is possible. Treatment choices for patients need to consider disease stages and the risk-benefit ratio for each individual. And we're very excited that first trials for women are emerging. So Caroline, I hope I didn't go too long, but I'm very glad to be here. Take questions later.
Merci beaucoup, Florian. Non, c'était très, très intéressant.
Thank you so much, Florian. So interesting. Every talk is important and every talk is interesting, but thank you for that. Thank you for sharing with us the prospects for treatments and new clinical trials for AMN. The adult form of the disease is important as well. There's been a lot of talk about cerebral ALD already. So without further ado, I'm going to hand over to Wolfgang Kohler. And for the last 3 speakers, please try and stick to the 20-minute time limit. I'm going to try to shorten my presentation because so much has been said already. So Wolfgang is a neurologist and a doctor at Leipzig, and he's going to talk about quality of life for women with AMN. And I think this is a particularly interesting topic. We're talking about that more and more, even though in recent years there hasn't been much talk about it, unfortunately. So many thanks, Wolfgang.
Hello everybody, welcome, bienvenue à tous. So I'm not yet successful to share my screen here.
We saw your slides for a minute. Now we see them not in as a slideshow, but if you can activate the slideshow, that should work.
If you just click on the full screen logo?
On what?
You can't?
Can you see my slides?
No, I'm the technician. You must go on your PowerPoint and go to the bottom right and click on diaporama. Yes, and now we have. Just a second. You see on the top left, you have, it's in Dutch, the middle one, you have a button, click on it.
This one?
No, no, we see your presenters. Can you leave the diaporama, please? Yes. Okay.
So now share the screen.
Yes.
Choose the screen.
Yeah, share PowerPoint. Yes. Now it's okay.
Okay. So I hope everybody can see and hear. Well, first of all, I really like to congratulate ELA for 30 years of successful work and the great opportunity for researchers and all over the world for being supported by ELA and in their effort to find new treatments. I think this is very helpful for many of us, and of course, finally for finding new treatments for the treatment of these rare diseases like leukodystrophies. So today I will talk about women with ALD and quality of life of this situation. We've heard a lot already about the disease itself, so I will not repeat it everything, but I want to emphasize that despite being heterogeneous for the defective gene, which means that one remaining X chromosome is not affected by the gene defect, women frequently may develop adrenomyeloneuropathy or myeloneuropathy symptoms, mostly less severe and later in life than men. That's like it was thought about, and only single cases with Addison's disease or cerebral ALD may occur. So adrenomyeloneuropathy is a slowly progressive disease which is affecting the spinal cord and the peripheral nerves. And the clinical presentation in women may be the spastic paraparesis. So this is the stiffness in the legs and gait disorders that are progressing over time. We see balance disorders, which we call sensory ataxia, pain, as we already heard, muscle weakness in the legs caused by peripheral neuropathy, and very importantly, urinary urgency, incontinence, so it's bladder and bowel dysfunction that is affecting the quality of life in the women. So, as I already said, cerebral involvement or Addison's disease is only very rare in women. So it was hypothesized that about 80% of women develop symptoms of such symptoms of adrenomyeloneuropathy during their lifetime. But usually it was hypothesized that the symptoms occur later and with a slower progression. And it's still the case that many of the women fall out of their diagnostic and therapeutic focus, mainly because of lack of awareness and the lack of knowledge of the symptoms of this disease in women by their healthcare providers and by the women themselves. So there's another big problem that women are usually not included so far in clinical trials due to probably a slower progression, which also causes the risk that the benefit from this clinical trial innovations may not be there for the women. So the new treatment options will not be applied in the women because they're not included in the clinical trials. This is a big problem. And finally, we see in women a higher risk for psychological stress, depressive grief, they're feeling guilty, and many other reasons that cause a high risk for psychological distress in the women, which is not addressed properly so far. So we wanted to know the quality, the situation in the women, the quality of life in the women in a larger group of patients. And we wanted to ask the patients themselves, the women themselves, what do they think about their situation in their personal life, not only looking at small cohorts from specialized centers that may be biased for some reason, but looking at the whole population of affected and non-affected women. So we wanted to know what is really the frequency and the severity of symptoms in these women affected with ALD. So far, well, it's an ongoing project. So far in the meantime, it's more than 200 women with ALD already included in this large project, which is supported by ELA and was done over the LeuConnect internet providing system, which is a very nice system for a goal like this. So we had in the meantime, 120 women from Germany, 30 from France, 14 from I must say 14 from the US, 8 from the UK and some other countries. What you see here is the age distribution, which shows you that what you can see is that women with younger ages are not yet properly included in the study. And this is something that I really want to emphasize. And we ask everybody who's listening to this talk to participate in the study, especially those who are younger, especially those who have no symptoms yet. But it is very important to hear about quality of life, even in this situation. So people who are already in the study may ask the family members from whom they know that they are already affected by the gene defect and others. So what I think is that we have seen, we would like to have a very similar distribution of ages over time. Let's say 25% in all of these age groups. That would be adequate to have a real life situation. But still, what you can see from the data that we have already, you see the increase of symptoms over time. In generally spoken, this is something what we expect, but we see a decrease of the of the numbers who are not affected by disease over time, but there are still some women in older ages who are not affected by the disease, but the symptoms or the affection by the disease is increasing over time. But again, I want really to emphasize that we need some more information about the women in younger ages. So this is extremely important. So let's go a little bit more in detail. For example, looking at the gait disorders, which is starting usually with stiffness or pain in the legs, insecurity of walking, walking difficulties of any kind. And what you can see here, that is that the gait disorder is increasing over time. So this is clearly age dependent, saying that younger women have less gait problems than older women. And this is especially true for if you look at the necessity to use aids for walking, which is increasing dramatically above the age of 60. But if you look at the wheelchair dependency, you see that about 10% of the women over 60 are already dependent by the wheelchair. So, which also means that 90% are still walking without or are not in the wheelchair, but most of them, 2/3 are using a stick or something, any walking aid. Oh, sorry. Sorry. So looking at bladder and bowel dysfunction, this is something which is different from the walking problems. As you can see here in these numbers, is that bladder and bowel dysfunction is present in high numbers already at young ages, and it is not increasing over time. So it is there or is not there. So patients with who are complaining of, for example, urinary hesitancy or urgency or even permanent incontinence, this is present at younger ages already, and it's persisting over time. The same is very much true for the sensory complaints. So let's say occasionally or constant pain in the legs. But you see, this is also a little bit increasing over time, looking at the complete numbness of the legs, which is more frequent in older women than in younger women. But still, sensory, like the bladder functions, are already there in younger ages, and they are not very much increasing over time. Sorry, kind of really problems here. So, okay. So, looking at chronic pain, so we ask the women, give you an example of how we ask this through our lives. Most of us had pain from time to time, such as minor headaches, sprains, or toothaches. Have you had pain other than these everyday pains of pain today? And so we see that 2/3 of the symptomatic women had additional pains, everyday pains, but already 28% of the asymptomatic women are complaining of pain. So this is a severe problem in most of the women. So looking at sleep problems, we're asking for quality of sleep, sleep duration, sleep disturbances, use of sleeping medications, or daytime dysfunction. So we're asking, for example, during the past 4 weeks, how often have you had trouble sleeping because you cannot go to sleep within 30 minutes, and so on and so on and so on. And so it came out that more than 80% of the symptomatic women had really problems with their sleep problems. So, and up to 60% of the asymptomatic women had already sleep problems. So this is a significant finding, I think. So looking at sexual dysfunction, we are asking for how often did you feel sexual desire or interest? How satisfied have you been with your overall sexual life? How often did you experience discomfort or pain during vaginal penetration? So this is present in about 38% of the symptomatic and 16% of the asymptomatic patients already. So restless legs was already mentioned by Florian's talk. So we asked, do you suffer from restless leg syndrome as described above, or have you been diagnosed for restless leg syndromes? And which is very much, I think the numbers are very comparable to what Florian is finding. We see about 50% of the women symptomatic for XALD that restless leg syndrome is present, but which is probably new, that is about 20% already or 21% already asymptomatic for the disease had restless leg syndrome. Depression is something which is also very relevant. So we asked the women for sadness, pessimism, crying, agitation, loss of interest, and many other things in this questionnaire. And we saw that 38% of the symptomatic women had depressive symptoms or criteria that met one of these questions as a positive situation, and already 16% who are asymptomatic with this disease. And even if we look, or if we ask further for suicidal ideation, like using questions like you see here, during the last week, I have a weak desire to make an active suicide attempt. For example, I have a moderate to strong desire and so on. So these are clear suicidal ideations. We see that this is present in 14 up to 15% of the symptomatic women and nearly 8% of the asymptomatic women, which is, I think it's very dramatic. So looking at the treatment frequency, so we asked the women, are you in treatment to any kinds of treatments? For example, seeing your neurologist or general practitioner, how frequent is this? You'll see, of course, that women symptomatic are more frequent in a regular treatment, but there are still symptomatic women that have no treatment at all. It is 15% that have no treatment at all, which is, I think, incredible. But we see that treated women, women who are in treatment, had a better physical health. They have generally spoken more symptoms, but they have a better mental health and they had less depression because they are in treatment. So it's very helpful to be in treatment, and it's dramatic that the 15% are without any kind of treatment. So this is an ongoing trial. So we are still looking for new participants to increase the numbers. I think this will be the largest questionnaire ever in women with ALD, either symptomatic or non-symptomatic. So we are looking for new participants, and you can easily do that going to the Lyconet homepage, register at the homepage, apply for the study, and then you can complete the questionnaires that are online available in 5 languages already, in English, French, German, Italian, and Spanish. It takes about 1 hour to get this information, and it is perfectly pseudonymized. There's no data storage, or with that it's possible to detect who is giving this information. So it's pseudonymized, and the whole evaluation is pseudonymized. So who can participate? So every woman either asymptomatic, and I really like to emphasize this is very important to have this information, especially from the asymptomatic and early, the younger patients and symptomatic women over the age of 18. So finally, I want to give you some information about a program that we want to start in May this year, which is called Smart ALD. So we want to address all these problems that the women have. We want to evaluate the effectiveness of a multi-approach lifestyle intervention, which we call Smart ALD, on physical and mental well-being and quality of life in women with ALD. So we have in this completely online program physicians that are giving medical consultation. We have psychological care. There's Lisa Schäfer here. She's a psychologist. And she is also very much involved in this program. There will be some information on psychosocial care for the psychosocial situation. We'll have some nutritional consultations, but also physical and fitness training during the whole program. So this is a study with the there will be a randomization of into two groups, an experimental group and a waiting list group. So the experimental group will start right away with the program in May over 1 year, and the waiting group will wait 6 months until they can enter this this program here, and then we will try to compare these two groups and find out if this multidisciplinary intervention is really helpful to improve the quality of life situation in women with ALD. Thank you very much.
Merci beaucoup, Wolfgang. C'était très intéressant.
Thank you very much, Wolfgang. That was very interesting. These questionnaires provide a lot of insight and very useful answers, and I'm sure we will learn a lot from those questionnaires. And we should encourage many patients and families to participate. Now, I'm going to share my screen, or attempt to do so.
Oh, you're more successful than I am.
It's okay, we can see it. Perfect.
Now, I'd like to deliver the last two presentations, Professor Dahl's and my presentation, regarding the pediatric form of infantile cerebral adrenoleukodystrophy. And because a lot has been said already, I'm going to shorten a bit my slideshow. We're late already and a lot has been said. But I would like to focus in my presentation on trying to convince the families and the patients on how important it is that this disease is screened as early as possible. Of course, sooner or later there will be neonatal screening for ALD. I hope so. In France, it's sometimes more difficult in France than in other countries, but right now we are facing a very sad situation in children, but not only children, adult people presenting with already the cerebral form of the disease, a stage at which there's nothing we can do. We unfortunately cannot do anything to slow down or stop the disease. So some background information. I will speak in French. My slides are in French. This is due to the fact that for the last 2 years, now that this meeting takes place via Zoom as a webinar, until now the meeting was in French and I spoke French because I was speaking mostly to French families, and I have kept this tradition. Next year, if we organize the meeting the same way, I might still deliver my presentation in French, but I will prepare my slides in English. So ALD is the most frequent leukodystrophy, 1 on 20,000 births, live births, so it's one of the most frequent rare diseases, and it affects the brain, the bone, the marrow, the spine marrow, the peripheral nerves, the adrenal glands, and the testicles in men. The mutation is gene ABCD1, as was explained by Stefan Kemp, and the marker is a 100% sensitive market in boys. It's dosing the accumulated acid, very long chain fatty acids. In the women, they may be used as a marker, but they may be more normal, and they are positive in 75 to 80% of the cases. This disease is X-related, X-linked, meaning that men with only one X chromosome, when they have the mutation, have the disease. But when the women have the mutation, they may show some signs of the disease, but not all of them. And this has already been explained. And when a woman has the disease, she may pass the gene on to the children, the offspring, but a man will only pass on the defective gene to his girls, his daughters. So here we have an ALD protein defect, and they default in the very long chain fatty acid degradation, which means that they accumulate and they lead to inflammation, neuroinflammation in the brain, leading to leukodystrophy. And there is also a number of other symptoms, for instance, axonal degeneration. And we know that in this disease, roughly speaking, oxidative stress and a defect in the energetic metabolism are also involved. And this is important because we are starting to acquire a better understanding, and maybe there will be new treatments which will be different from gene therapy or marrow transplant, but in the future they may be helpful, although they possibly will have to be given as a combination with the other existing treatments. The infantile cerebral form is the one we're going to talk about today, which appears during childhood. 35% of the boys born with the ABCD1 gene mutation will develop the cerebral form of the disease. So it is very important that we look for it. The adult form is called adrenomyeloneuropathy, and I will not go over this again, except that even an adult man may develop the cerebral form of the disease. And the frequency is increasing because now we are screening them earlier, and 35 to 50% of the men with a mutation with AMN will develop signs and symptoms and the cerebral form. And the adrenal failure is a very important sign of the disease. There may be severe symptoms when men are suffering from adrenal failure. And if it is an isolated issue, and then the men will develop AMN, because AMN has a total penetrance, 100% of the men will develop AMN signs and symptoms. The clinical forms, there is a continuum in the forms. The presentation difference based on the age has been explained by Florian. Here we have a curve showing that men will develop AMN, and a large percentage of those men develop a cerebral form of the disease, and the frequent in the adrenal failure is almost 100% penetration. We have no markers that will tell us which forms we're going to evolve towards. There's no biochemical marker. So it's very important that we look at the whole family, looking for men who potentially may be carrying the mutation and are still asymptomatic. And we also can look for women who will carry the disease and pass it on, or themselves develop symptoms. Now, there is a large clinical variability even within the same family. There may be very different forms of the disease appearing in the family members. That's something that we have to repeat again and again. Family investigation or study or inquiry, whatever. It is very important, and we still don't have enough screening for that. In the majority of cases, the mutation is passed on by the mother to the sons. Rarely, it is a de novo mutation. When an index case, the first baby boy in the family has a mutation, the mutation happens by chance, randomly, and that's the de novo mutation, and no one else in the family suffers from the disease. For us neuropediatricians, when we see a child with ALD, or when we are informed by our colleagues regarding men or women carrying the mutations, we're obsessed to look and we look for all the boys that are at risk of developing either the leukodystrophy or the cerebral form during childhood or adrenal failure. And this is a neurological sign, but X-linked transmission is very, very extended. And so in as far as we can, we should absolutely look for this disease in the boys. And cerebral ALD, for the parents who are listening to this conference, maybe either they've had a child suffering from the cerebral form, or maybe they have adult members of their family suffering from the cerebral form. In childhood, it's very difficult to diagnose the cerebral form early, and it's difficult to detect it, screen it early enough to be able to offer a treatment, especially when the child is the first child in the family suffering from the cerebral form, because there is a very insidious form that may last up to 18 months with very specific symptoms, with symptoms, which are not evocative of anything. You know, problems in school, behavioral issues, and when the first time we make the diagnosis in a family, it's because the child has attention-related disorders. The disease is diagnosed, and then it starts evolving relatively rapidly due to the neuroinflammation, leading to rapid degeneration and regression. In less than 1, maybe 2 years, the child's state will worsen, and the child will finally develop loss of communication, blindness, will need to be fed with a gastric probe, the child will become dependent, will no longer be able to walk. And there are so many signs that are very difficult to detect early and are very difficult to manage once they are established. Again, here we have a few tables a few situations that should be evocative of the disease. And when that kind of symptom is present, the cerebral lesions are already relatively advanced. Here, for instance, we have a child with melanoderma, a child who is exceedingly suntanned, and that is one of the signs of the adrenal involvement, especially during the wrong season. If a child is suntanned in the middle of the winter, that is evocative of an adrenal failure, and especially in a boy, endocrinologists know that, and that should be an evocative sign. Also, boys in the age between 4 and 8, when they start going to school and have attention troubles, have learning disorders appearing abruptly. A child who is doing well and all of a sudden has behavioral problems or school learning problems. A child who also has vision or hearing problems, has progressively more and more difficulties walking, coordinating, spasticity, pyramidal syndrome. Those are all evocative of disease. And now back, I would like to, later we will talk about how to monitor the children. I mean, that's already been talked about earlier, but I'd like to say a few more words. On this slide, where the little yellow arrows are, we find the white dots, which are cerebral ALD incipient lesions, very early lesions. At this stage, there are no clinical signs. This is the very beginning of the disease, and at that stage, we can still offer a treatment that will block the disease, stop it from evolving. So it's very important to monitor the children. When there are no symptoms, and if we're not aware that the disease is present in the family, there's nothing we can do. But when we know that the family already has people affected by this disease, then we should monitor all the children. How do we monitor boys, young boys who have been diagnosed and screened because we looked for the mutation or the very long fatty acid chains? either because they had signs of adrenal failure that led to the disease being diagnosed. And as was said by Stephen and Florian, we monitor the cerebral MRI starting at the age of 2 every 6 months until the children are 12 years old, and then once a year. And we are pushing back the age at which we stop looking at MRIs, and so we're still looking for that very little white dot, the little lesion that will trigger treatment.
Une fois de plus.
Now the adrenals, that's an important sign. Let's not neglect it. We check the child every 3 to 6 months. Then, obviously, not so frequently in adults. And of course, in adults, we look for signs of AMN, so we can treat the symptoms. And as Florian Eichler said, there are experimental treatments available as well. So here's the message. When it is possible to detect cerebral ALD early enough, it's treatable. It's pretty much the only treatable leukodystrophy. So that's important. I'd like to emphasize that the importance of that study. So you can transplant hematopoietic stem cells, whether from umbilical blood or from bone marrow. We can use ex vivo gene therapy, and these two treatments will be addressed in the next talk. And then there are clinical protocol type treatments that I will say a few words about. I'm not going to get back to what I said before. We need to treat very early on, before the symptoms appear, and unfortunately, most of the time it doesn't happen. Let me say a few words about symptomatic treatments. So whether curative treatments or whether clinical protocols, obviously treating the symptoms, in most cases, whether in children or in adults, treating the symptoms is important. Saying that there's no curative treatment doesn't mean that you shouldn't provide care. Now, medical care and quality of life should improve, and we should not wait for those treatments to be available. We need to start treating as soon as the early symptoms show up. In cerebral ALD, there's often a rapid deterioration. So as soon as the symptoms appear, you got to treat them. When the stiffness or the pain appears, you have to treat it right away. You need to adjust the treatment, well, maybe not 2 or 3 months, but maybe every 2 weeks if necessary, every week if necessary. You also need to anticipate maybe there are orthotics or devices that you can bring in. It's going to take a little while before they're paid for by Social Security, and so you need to stay ahead of the curve. You need to look ahead, and there are tertiary reference centers that are there. They were created some time ago. And in every pathology, in every disease, they provide help and information to both families and carers. I'd also like to emphasize the need for a multidisciplinary follow-up. Here's a list of professionals who should be involved. It's important for those professionals to talk to each other as well. And they need to be brought together as part of regular multidisciplinary meetings, so the entire patient management strategy can be adjusted as needed. So I talked about transplant, I talked about gene therapy, I touched upon it, but regarding cerebral ALD, there is a clinical protocol that is currently under evaluation. We touched upon that before when it comes to the adult form of AMN, but this drug is called leriglitazone and is currently being assessed for treatment of cerebral ALD in children. It's called Nexus. So let me say a few words about that. This drug is a PPAR gamma agonist derived from a former anti-diabetic drug that's been around for a long time, pioglitazone. So it has very interesting properties when it comes to reducing neuroinflammation and maybe even preventing neuroinflammation. And that's the sinews of war, isn't it, in cerebral ALD? And there's also a positive impact on oxidative stress and mitochondrial function. So those are not effects that are specific to adrenoleukodystrophy, but it's a good candidate. Good intracerebral penetration. It goes into the brain well. It is administered per os, orally. It's well tolerated. Safety is good. And so the Nexus protocol in children seeks mainly to prevent or mitigate inflammation and demyelination. So the idea is to administer the drug early, so as to potentially stop progression of the disease and avoid having to transplant hematopoietic stem cells. This is a highly ambitious goal. But clearly something that we need to assess. So there are 4 centers involved in the Nexus study, and they're enrolling children. 4 centers in Europe, including Hospital Bicêtre. This is an open study. There's no placebo group. In total, 13 children will take part. They're aged 2 to 12 years with incipient cerebral ALD. So the demyelination score is low. There's neuroinflammation or not. In both cases, the child can receive the treatment, and of course we exclude certain pathologies, and that's true for most clinical trials. At the moment, 12 patients, 12 children have already been enrolled. Of course, the results are not available yet, but preliminary results should be taken with a pinch of salt, because we're far from having reached the end of the study, but they seem to show a slowdown in the progression of the lesions. And I'm using a question mark here because you've got to take it with a pinch of salt. Now, in terms of treatment possibilities, when you're dealing with a boy, a child, a young boy who is screened and who's showing a gene mutation or an increase in VLCFAs, if there's no cerebral ALD in the first MRI, we're going to look for it in other MRIs. If there's a small incipient inflammation or lesion, but that shows no inflammation yet, you got to watch it, because in some rare cases the lesion can stop. There are arrested forms of cerebral ALD, so you got to take the time to check. And then also, of course, we can propose treatment as part of the Nexus trial. So if the lesion shows inflammation, then a transplant is indicated. And we will trigger the quest for donors, either within the family, or we look at compatible matched donors. And we can propose MIN 1 or 2 if transplant is denied or impossible. So in France, together with Jean Vidal and his colleagues from all of the neuropediatric centers and also the transplant centers, we have set up a multidisciplinary meeting during which we present all of the child and adult cases, so we can discuss whether or not to perform the transplant. So this is my final slide. Now, this information is about France, but there are reference centers for leukodystrophy where patients can find information. There are 3 component centers and 3 competent centers for both children and adults. When it comes to ALD specifically, very often children are referred to Kremlin-Bicêtre Hospital, and adults are sent to Pitié-Salpêtrière, where doctors Michel and Yazbek are working. And there are other reference centers located in Montpellier and in Lyon. And all of these hospitals communicate with each other. We talk all the time. So, under the aegis of Fanny Moschel, we have tried to set up a network for family screening together with genetic counselors and geneticists throughout France, and they've been trained to meet with families and provide them with the explanations that they need. Also, we're providing nationwide coverage for monitoring, for follow-up. Not everybody has the good fortune of living or residing in Paris, Montpellier, or Lyon. So if you don't live in a big city, you can still refer to a reference center. And we talk to them, we monitor patients, and then, of course, the multidisciplinary meetings for recent initiatives that have been set up for both children and adults, for example, transplants, etc. So without further ado, I'm going to hand over to Jean-Hugues. Professor Dag is a hematopediatrician at Robert Debré. We like to work hand in hand. That's something we like to say, but it's true also for his patients. We talk to them about transplants. He creates his treatments for his patients, and these treatments include gene therapy. And he's going to talk about the main results of cell and gene therapy in the treatment of X-linked cerebral adrenoleukodystrophy in children. Thank you, Jean-Hugues. I hope I didn't take too long. You're good. Don't change anything. I was making sure my microphone is open. Good afternoon, everybody. Thank you so much for inviting me. Thanks to the previous speakers for their talks, I prepared my slides in English. I will try to comment on those slides in French, because you don't want to hear my English, let me tell you. It would be silly. It would make no sense for the French families to have to suffer through my English. So I will try to not to get mixed up between English and French. So a lot has been said already, so I'll try to go quickly, because the clock is ticking and we all need a break. So these are the main results of cell and gene therapy in the treatment of X-linked cerebral adrenoleukodystrophy in children. Of course, bear in mind Guy Alba's reservations regarding the fact that gene therapy is not currently available. My conflicts of interest, everybody's got conflicts of interest, particularly when it comes to Bluebird Bio. First, I think it's important for you to know what my potential conflicts of interest are. I'm not very nice to Bluebird Bio. It's possible to work with an entity without necessarily agreeing with what they do and how they do things. So this is something you know by heart. The physiopathology of the disease, the ALDP mutation, which stops the VLCFA breakdown. So they accumulate mostly, they build up in the adrenals. This leads to cerebral problems, and there are different forms of the disease, asymptomatic in particular, but very few patients are involved, adrenal insufficiency, AMN, and lastly, cerebral ALD. It's difficult to determine the level of severity. And it's difficult to determine which form is best to have. I mean, it's not like people have a choice. But 35–40% of boys with ALD will develop cerebral ALD. So this slide is something that Caroline already showed. What's interesting is what you see here. See the change in the disease? You may not be a doctor, but clearly you can see something's happening in the brain. We're not supposed to have these huge blobs there. We're not supposed to see the white matter like that. Now, leuco in Latin or Greek means white, so there is an anomaly, an abnormality that affects white matter in the brain, and this is what causes the disease. So as Caroline said before, this is where we come in. This is where we need to step in when the initial symptoms show up. At the very beginning, when the initial clinical signs appear, because otherwise it'll be too late. We won't be able to turn things around or impact the course of the disease, the progression of the disease. It's important to know that for the rest. So I'm sorry that I have to show you these curves. You probably have seen them 1,000 times. You know them better than I do, because I know that many of you have been affected in your very soul, in your flesh. Now this graph shows the outcome of patients. See the overall survival of patients with the disease. And see here, at 10 years, that's the patient's age, or that's 10 years after diagnosis, less than 50% of patients survive, and less than 40% of patients are MFD free, are free of severe motor function disorders. This is absolutely tragic. And if we look at those who are diagnosed with inflammation, well, these curves are even worse, even more tragic, even more scary. Now, it is really important to know that we have been able to set up scales so we can locate the child, situate the child on the scale when the disease is diagnosed. Now, some of you may feel that these scales are too abstract or chilling, but when we initiate gene therapy is particularly important in terms of what happens to the child. And for us, it's really important to know exactly where the child is, what stage of the disease is at. So for that, we use different scales, different scores. Now, Caroline and other people have discussed these scales, including the NFS, the neurologic function score, and also there's an X-ray based scale, the Lewis MRI severity score. This gentleman is a radiologist from the US. So the NFS goes from 0 to 25. The lowest score goes up to 34. And this is why we decide that we need to take action now. When an injection of gadolinium actually enhances the imaging. Now, the very first allografts, allo means other, so transplanting tissues or cells from someone else and not your own tissues. So the first allografts date back to the 80s. So this is an old paper. And the entire international community was interested in the result. So it's about cerebral X-linked ALD, international hematopoietic cell transplant experience from 82 to 99. So as you can see, the number of patients increased from one period to another. Okay? And if we look at the median age, at the time of transplant, it's about 9 years. So what do we see? Well, this is not based on the same work. But what do we know about the outcome of these children? What happens to them after transplantation? An allo transplant. Remember, the tissues come from someone else? As you can see, overall survival is pretty good. I'm not saying that there aren't tragedies that can't happen just after transplant. Transplant is a treatment that can be very dangerous. It can be very dangerous. There can be complications that are life-threatening, that it can kill the patient that you want to transplant. But if you look at the green curve, the neurological outcome for those patients, these are patients who receive a transplant at an early stage of the disease. Obviously, the progression isn't perfect, but it's by and large much better than the curves you saw before. However, if we talk to patients with advanced disease, overall survival is by and large okay, but there's one event here. See that step there? See that sudden drop? But if you look at the neurological progression, it is absolutely disastrous. The steep decline there, and this shows that transplantation has zero effect on neurological damage. So transplanting, yes, transplants work. I'm not saying there are no risks, but they work, and they work because you do it early. And I'm talking about allografts, tissues from someone else, not your own tissue. So again, this is the overall survival, and you compare the patients with transplants and the patients without transplants. See, it's a misnomer. It's not even a question look at the benefit on overall survival from transplanting. But of course, there are risks and there are limitations. There is something called treatment-related mortality. It's pretty strange, I know. It's pretty rare in medicine. I mean, a treatment's supposed to help the patient, save the patient, not kill him. But depending on the authors, there can be between 8 and 19% treatment-related mortality. So mortality not from the disease you're trying to treat, but mortality from the treatment itself. And the graft failure can be as high as 18% when the host rejects the graft. So graft versus host is what it's called. So there's a conflict between the donor cells, which are supposed to correct the neurological pathology, and the rest of the body of the patient, which rejects the foreign cells. So when you're looking for a donor, you want him to be perfectly matched, perfectly compatible, so as to reduce the risk of complications from graft versus host. So these are intrafamilial, matched-related intrafamilial versus match-unrelated donors, mismatch-related. In other words, they don't entirely match, and they're mismatch-unrelated. So 4 different groups. And as you can see, overall survival is much less good when you have mismatch-related donors. And this shows that it is an imperative. We need to stick to donors who are matched in order to achieve good overall survival. And what else do we see here on these graphs? But much more so here on the right-hand side. See the Lewis score, changes in the Lewis score, depending on whether the transplant takes place at the early stage or the advanced stage of the disease. So early disease 1, very early stage, and then early disease 2, halfway, sort of in between, and then advanced disease, that's the later stage. So again, this is imaging mostly, but whether we look at imaging or whether we look at NFS, neurological function score, an early transplant, good. You don't do as well if you wait a little longer, and the longer you wait, when you get to the advanced stage of the disease and you wait for the transplant, then you do much worse. So the earlier the transplant, the better for the child. Next slide. I'm skipping one slide for the sake of time. So together with Bluebird, we worked on 2 prospective trials, ELD 102, ELD 103. Actually, ELD 102, ELD 104, those are gene therapies. And then ELD 103 tries to describe what happens to a patient depending on whether they received an allotransplant or a gene therapy. So I won't go back to what gene therapy is. Here we don't need an external donor. The patient is his own donor. The patient donates his own cells, and they're going to be infected with a virus in which we transfected a gene. And so once the cells have integrated the virus, which contains the fixed, the corrected gene, we send it back to sender. So the child is exposed to a number of complications. High-dose gene therapy can cause complications. So 2-year follow-up and then 15-year follow-up in total. It's compulsory for all gene therapies. That's the way things are. So almost 60 children have received a gene therapy. In those 2 trials, of course, we ensure quality control. And then we have quite a bit of follow-up for some of these children. Now, what do we see? You may think that this graph looks very much like what I showed you about allotransplant. Now, the children who received gene therapy in the first trial are doing well. That's the line in blue. Now, in the ALD 103 trial, we try to compare them with the population that did not receive gene therapy, and this population, as you can see, is not doing as well as the children who did receive gene therapy. So here, in ALD 102, you have 3 patients, 3 children who did not benefit from the gene therapy. One of them, unfortunately, died from the disease, from the progression of this disease, and 2 withdrew to undergo allo-HSCT. Now, in ALD 103, which is a matched cohort, there are 3 patients who died. of the transplant or died of the disease. 5 patients progressed despite the transplant and underwent a second allo-HSCT. And very recently, actually since early 2021, in gene therapy trials, there are 3 cases of MDS that have emerged. MDS is akin to that. We know that gene therapy actually modifies the genome of hematopoietic stem cells, and the virus, when the virus infects the cell, it carries a gene, and when that viral gene moves into the genome of the hematopoietic cells, there was a chance that it could find itself adjacent to oncogenes. So these are genes that, when you trigger them a little bit, can lead to MDS, myelodysplasic symptom. And this is what happened in 3 children out of the 60 children who were treated. Unfortunately, this is not good news. But it doesn't mean we should stop treating this population. But it is true that, of course, we're very worried. We have a lot of questions. In particular, what did we do wrong? What should we change to make things different? So what's interesting here is that in blue, you have the treatment who received gene therapy. In black, you have the children who received HSCT. And if we look at the LUZ score, and more specifically, even more, the NFS score, we find that both techniques have the same benefit. When it works, the children overcome the severity of the treatment. When the children overcome the severity of the treatment, then they do very well. Okay, I'm going to skip that slide. What do you need to take home? Whether you receive gene therapy or whether you receive HSCT, by and large, you're doing well. The patients are doing well. The results may be slightly better for gene therapy than for HSCT. However, there's a terrible problem. My phone just rang. Apologies, I lost my train of thought. I got distracted. There's a huge safety problem in the gene therapy arm, unfortunately. Unfortunately, as Guy Alba rightly said before, despite the marketing authorization delivered by EMA in spring 2021, Bluebird made a tragic decision, an unjustifiable decision to pull out of Europe, which means that European children affected with the disease are denied the treatment, and this is not respectful of the patients, not respectful of their parents. So we had the time to treat 7 patients using the Bluebird product before they pulled out, and very recently 1 patient for MLD. Well, this is not the disease we're supposed to be talking about right now, but we did. Thank you very much for your attention. Many thanks to all of the participants. If you have questions, I am on hand. Thank you, Jean-Hugues. I was busy answering questions via the chat. I don't know how much time we have. Well, we were planning to have a break at 4:25, which was 3 minutes ago, but we can overspill by 15 minutes if you'd like to take questions. Yes, of course. So how does that work? Those families who want to ask questions should raise their hands virtually, click on the icon via Zoom, and then we'll give you an opportunity to ask questions orally. So let me activate your mic. The first question can now activate their microphone. Edric Beer.
Hi. I actually have a question regarding PMD, like the Pelizaeus-Merzbacher buffer disease. We didn't spoke about it, I think, yet, right?
PMD will be presented in the following part of the afternoon. Maybe you can reserve your question for the second session of questions.
Well, you're talking about today or tomorrow?
Today, later today.
Okay, so I'm waiting for it. Thank you.
Thank you. So now we have a question from Assumption Bosch. If you'd like to open your microphone.
Sorry, no, it was a mistake. I was just trying with the with the platform. Sorry.
Very well. So there is no. Here we go.
If I can ask a question to Stefan Kemp. Stefan, what do you know about the specificity and the sensibility of newborn screening? In other words, do you felt some patient with ALD? Do you have some false negative and false positive patients? Or not patients, but screened babies, I would say.
That's an excellent question and a very important question because in many newborn screening programs for diseases, often false positives are identified, meaning that that a family and a child is sent to a specialist, and then it turns out that the child does not have the disease, and of course this is very stressful. And I can say that in our pilots we referred 4 children to the specialist, and all 4 children had a pathogenic or a likely pathogenic variant. And they all had elevated very long chain fatty acids or elevated C26 lysis PC. And one of the 3 had a proven pathogenic mutation, so that has been associated with disease. And why I say that the other ones have 3, the other 3 have a likely pathogenic, is that these are variants that have not yet been identified in patients with disease. And that happens a lot in ALD. So, but it's critically important that these boys are now in a follow-up program with the appropriate measuring, because only time can tell. But so the positive predictive value of the program is 100%, which is extreme. But it's an excellent question. This is.
Une question from Sigrid Marais.
Question from Sigrid Marais. Can you hear me?
On vous entend.
Good afternoon. We can hear you. I have a question because I suffer from AMN. I was diagnosed 2 years ago, and I've been waiting for the diagnostic for 20 years. You were saying that it started very early. I had all the symptoms that you described: gait, difficulties, bladder dysfunction, and I'm still working, and I am not being supported. I don't have a geneticist taking care of me. It is a neurologist who actually diagnosed me and started the genetic testing. So who do I turn to? I have no support. Maybe I could have information. I have a treatment. I receive toxin injections in my legs and in my bladder. It's the first time that I'm attending this conference, and I wanted to maybe get some useful information. Do you live in France? Yes, I live in France. Yes, absolutely. Well, maybe we can talk about this offline together. Of course. If you would like to get some information to see how you can organize someone to take care of you, you could contact the Reference Center for Adult Leukodystrophies, and you will get some information, and you will be referred to a specialized center. I was diagnosed 2 years ago, and 2 of my boys are gene carriers, and they are now being monitored in Angers. They both have adrenal failure, and they already have had 2 brain MRIs. For now, there's nothing in their brain, nothing wrong in their brain. But the youngest one, Timeo, is 13 years old. He has a therapy for both hormones. Yes, hydrocortisone. And as of this week, we started the second drug for the second hormonal failure. Yes, he's being followed by Dr. Bartet. Yes, I'm aware of that. I was talking about the network, the grid for adults. And for children, there are very few reference centers. Maybe it's even more important for children than it is for adults. Neuropediatricians who are in charge of children talk to us all the time. If the MRI is fine, okay, but otherwise they talk to us, they're in contact with us. So for your children, I trust the doctor who is taking care of them because I know her and I know she's doing a great job every time. So you shouldn't worry about that. And for you, well, it's okay. I'm fine. I mean, I will ask the question later. I would like to leave the floor now to other people if other people have questions. Okay, Magali will give you my my phone number or my address. Thank you. Thank you very much. We have written questions. There's someone asking for the risk percentage for developing the cerebral form for a man over 50, and until when? Until what age is he really at risk? Florian, would you like to answer?
Sure. So I also wanted to comment on the past question. There are international clinical care guidelines that many of the specialists and clinicians have worked on together that will be published this year and hopefully will help patients like Sigrid when she goes to her provider asking for standards of care and knowing what kinds of specialists need to be seen at what intervals. The risk for cerebral ALD decreases dramatically with age. And I would say it is far below 20% by that age. But it is still a risk. And so I do encourage my patients to continue to get MRIs up into that decade. I would like to hear what Wolfgang thinks about that, in particular because as patients get older, there is a question on what is actionable and what you still proceed to something like a bone marrow transplantation. And it might change as we get other therapies to be available.
Yeah, Florian, I fully agree. There's I would like to say the impression that the risk is decreasing over time, but we don't have valid data on this yet because of the numbers of patients. I think this is something we should discuss internationally. We currently working on this problem with cerebral ALD in adulthood, and we're looking at 80 patients over time. So maybe there's some results coming out of these measures, but yes, there's still a risk even at higher ages for cerebral ALD, but then it occurs that concomitant diseases coming up with age as well. So it's getting more difficult to apply stem cell therapy in people with older ages because the risks are higher. So these are many problems that are still unsolved. But currently, I think it's very important, as Caroline already said, that there are specialized centers in every country. So every single patient with such a severe and complicated problem should show up in one of these centers, and it needs to be discussed individually.
I agree. Alors après, il y a une question, mais je ne peux pas la traduire.
There is another question that I cannot translate. Elise? Are there any other questions? Yes. We have somebody raising a hand.
Can you hear me?
Oui.
Okay, so I was wondering
Yes, we
if
can.
there is any clinical trial for a PMD. My son is like 7 years old and he can't wait for like a medicine. Every day he's asking me, is there a medicine yet for me? Like, is there anything on a PMD for like clinical trial, something?
Again, well, I guess we'll take your question in the second part of our afternoon. At the end, there will be another session and experts on PMD will be able to answer you. Thank you.
Thank you.
Je pense que c'est parce que nous sommes en retard et donc il y a
Well, I guess we're late and there are people from the next session starting to connect. So maybe we could thank our speakers for the first part of the afternoon. We will take a 5-minute break. We will shorten the break to 5 minutes and we will be back in 5 minutes for the second part of the afternoon. Thank you, Caroline. Thank you to all the speakers and to all the families who attended this session, and see you all soon.
Thanks a lot.
Bye.
And I will leave you the microphone to start the second part.
Thanks very much, Elise. It's a pleasure to be here to report to families. This will be a session with 4 speakers, and we'll be discussing hypomyelinating leukodystrophies, including Pelizaeus-Merzbacher disease and 4-H. I'll ask the speakers to try to stay on time. The talks will be 20 minutes, except for Nicole Wolf, who will have 40 minutes. And we start with Isabelle Thivot, who is going to tell us about new advances in diagnosis. Thanks very much, Isabelle.
Thank you. I'm going to start sharing. Share. Can you see the slide?
Yes.
Perfect. Technology sometimes. Thank you so much for the introduction. My talk will be very different than the other previous talk, but I hope you're going to enjoy it. Oops, just a second. So it's going to be a 3-part presentation. I'm going to start with presenting the center and our program, Genetic Answer for Kids. Then I'm going to talk a little bit more about the different technology that we're using, including the 3rd-generation sequencing, and giving you example in neurological disorders that include leukodystrophy, but are not pure leukodystrophy cases. And then I'm going to present you an example of leukodystrophy patients that have been enrolled within our program. So starting with our genomic answer for kids. So as you may all know, there's a lot of genetic disorders that has been described. So we are talking close to 7,000 different human disease. But more importantly, even those diseases are rare, when we look at the numbers, it's actually affecting a lot of children. So it's 1 in 30. And this results in 1 in 6 children hospitalization or admission, and 1 in 5 infant deaths. Genetic disorders are often heterogeneous, and this is true for leukodystrophy, leukoencephalopathy, for which we have already more than 700 genes that has been associated with those diseases. The mode of inheritance, however, is also the same for any other neurological disorders or genetic disease. It can be recessive, autosomal dominant, X-linked, and even from mitochondrial genome. So definitely using next generation sequencing, we saw an increase in gene discovery, disease discovery, but still, even with very good phenotypic presentation that we are highly suspicious of the genetic disorders, our diagnostic rate remain between 25 and 35 if we are conservative. And those rates are exactly the same for leukodystrophy, except for the ones that are highly specific on the brain imaging. So using short-read sequencing has been definitely like the go-to for clinical testing. And then more and more people were thinking that using genome sequencing, so looking at the entire genome instead of just the gene or the coding of the gene, might increase the diagnostic rate. However, from our experience and other publication, it is increasing the diagnostic yield, but it's not as much significant that we would want it to be. So our program is definitely a resource that we want to put together, a pediatric repository to find answer for those family undiagnosed, but also for the family that do have a diagnosis to look at more genetic modifiers or work with other partnership for developing treatments. So the yield that we want to reach, it's actually, we got the funding for 30,000 children and their family in the next 7 years. We are using a very dynamic, comprehensive sequencing and analytical strategy that we are moving forward every couple months, and even every year we readapt our strategies, which include reanalysis with new software, new pipelines and tools, realignment, but also resequencing with new technology. So where we are, you can tell from my name and my French accent that actually I'm from Montreal, and I needed to look at the map when I got the job offer from Children's Mercy. So we are located in Kansas City, which is in the Midwest, and we are a nonprofit children's hospital. Thinking about the comprehensive sequencing strategy, so we do use what we call the standard genetic testing. So we would use, especially in families that didn't have any genetic testing prior to be enrolled within our program, we would do exome sequencing, but also short-read PCR-free genome sequencing. Aligned with that, usually in parallel, we would do whole genome bisulfite sequencing, and we would also do single-cell genomics, looking at the RNA, the transcriptome, at a regulatory region, and we are also using those tools in PBMC, but also tissue and induced stem cell. What we realized within our initial months of the program is that even using those tools, we were still not increasing significantly our diagnostic rate. So we decided to use third generation sequencing. We started using the 10X technology, but now we are only using long read sequencing using the PacBio technology. And I'll explain to you a little bit later what it is. So I'm not going to go into the detail of this, but basically we try to use the most sophisticated way and fastest way to capture the family data, and we tend not to recruit only the affected proband, but also the unaffected sibling to increase the power of our analysis. And then we capture the phenotype of the patient and the extended family members within what we call phenotypes. And this is capture and link to the sequencing data in the cloud. We are using a lot of custom tools, but more recently we added Imaging, which is a commercial tool with a very, very strong artificial intelligence to try to prioritize variant and also do gene discovery at a fastest level that a genomic analyst can do. So when we were talking about adding discovery layers, one aspect of it is that, as you may know, most of the NGS testing or clinical testing, we're using the patient NGS data and we compare it to a reference genome. But the reality is that the reference genome is not necessarily a good representation of all the genome that exists. And this is what makes us different from one person to another one. So we realized that maybe some of the mutation that we're missing or diagnosis that we're missing are usually masked or because of the bias of trying to use the reference genome. So we call it the personal genome. And then we believe that doing a personal genome, so we're going to be able to unlock some genetic variation that we're missed, to see different transcript, to look at regulatory region and have different config. And I love this image that I took from a Nature paper that gives you like the reference genome on the top and taking two individual genome and see how they look different. So looking at the same region, you see that within those different regions, there might be gaps or there might be regions that are not even part of the reference genome. And indeed, in those specific regions that we want to focus on, this is where maybe a genetic variation, which is disease-causing, might be located. And we did that on several undiagnosed cases, and we note that most of those regions that are not present in the reference genome are less than 100 kb, so not very large regions. But most significantly, when you look at those specific regions, in every individual for which we uncover those a new assembly region, there's more than 100 genes that were not detected using the reference genome. So this is very significant. And then we can look at those regions and combine with the transcriptome and try to see if any variation or changes just by the mislocalization of those regions might affect the gene expression or the pathway. The other functional layers, because looking at those different type of variation, we need to do some functional studies. So we're not going to do, especially when we think about leukodystrophies or we think about neurological disorders, we're not going to do a brain biopsy on our patient. And using the blood, most of the genes that are important for brain development, myelination, are not expressed in the blood or very, very weakly expressed in the blood. So we cannot use the blood as a good way to look at the transcription of the gene or the pathway expression. So we use the PBMC from the patient and then we deprogram them and reprogram them into the tissue of interest. So for leukodystrophy, for example, we would do neuronal differentiation. And then we can use those neurons and do more functional data and look not only at the expression, but look at those regulatory regions and look at the impact of variant of unknown clinical significance we might have detected using NGS. And the reprogramming of those things take between 8 and 12 weeks. Another aspect of our program, and for me that was important to share with you today because I know there's a lot of family, but there's also a lot of researchers and this meeting. So it's that all our funding has been from a private donation philanthropies. So for them, it was very important that the data was not locked within Kansas City, but available for any researchers or any people with interest in genomic or gene discovery. So we released just a year ago our first block of over 1,000 individual sequencing data, which include genome, exome, long-read sequencing, and RNA sequencing into the dbGaP program. And actually, we released in 18 months more data than the undiagnosed network program at the NIH, which has been running for 6 years. So we are very proud of that. And we do some direct partnership. And the first partnership we have done is with Care for Rare in Canada to try to do data sharing, but also tools sharing and phenotyping information of our different patients and families. So our program is still young. As a year ago, we were at about 18 months. So we are close to 2.5 years now. So right before the pandemic, and we've been impacted, obviously, like all of us, in research, but also in recruitment of the patient. So the COVID reduced our access to the clinic. So most families would go to, would either report their medical appointment unless it's highly necessary, or we would do telemedicine. So to get the sample that we need for the genomic analysis became very struggling. So we started to use partners of private lab for which the family can go to a small clinical blood draw. We can put the order and then we would pay for the shipping of those samples to us. We also started to use more buccal swab or saliva testing for the parents and the unaffected sibling to be able to send the kit at home and then the family can ship it back to us. So it did slow down our ideal recruitment phase. So we are far from the 30,000 families and that we want, patients and families we want to recruit. But still, we've been, just like other people, very much struggling. Another aspect of the COVID was also the reduction of the research. So the hospital decided to reduce to less than 25% the number of people that could be on site during a year and a half. So obviously we didn't have all the resources in the lab to work at full capacity. And another aspect is that the institution decided to reallocate some of our resources to have a program that is looking at COVID-19. So those in the bottom of my slides is actually some of the slides that I presented a year ago at the American College of Medical Genetics. They were our a preliminary data. So we knew from not only the adult onset, but from some of the research that were continuously being published, that even if children most of the children didn't have severe COVID, the children that are at high risk to develop severe COVID or long-term complication of COVID are children with medical condition. And that is very true for genetic conditions such as neurological and metabolic disorders. So we decided to look at those specific cases and then do a retrospective analysis for the family that were already enrolled within our program and look at all the targeted gene and pathway that were published in the adult onset cohort and look if any of our families or our patients were having markers or mutation in gene and within the pathway to flag those families that could be at higher risk of developing severe COVID or long-term COVID. So we published those data a year ago, but this is obviously an ongoing project. And with the new variant, we know that now can develop more COVID than it was with the previous variant of COVID. So now I'm going to switch into the second part of the presentation, talking a little bit more about technology. So genomic is so changing rapidly, and we compare it to the Midwest forecast. You never know how fast it's going to change. So just talking back to the basic genetic of genetics, from Mendel to the double helix to the chromosome number, and then the Sanger, which is the first type of sequencing that we're using. It took a long time to get to this reference genome that we're using. It took about 13 years and $2.7 billion to sequence it. And then talking about that, so then every time the technology was increasing, and we published in 2012, being able to sequence one genome in 50 hours. And then 4 years later, we were able, using different bioinformatic tools, different compute system, to cut it in half. And then the technology is evolving not just on the bioinformatics side, but also the machine that are doing the sequencing. And in 2017, Illumina released the NovaSeq 6000, which allow us to sequence 60 genome in 3 days. So now the bottleneck is not the ability to sequence, how fast we can sequence, but more on the side of the genomic analysis and the lab directors or researchers to look at the data. And then, even though it was first described in 2008, it's only since 2019 that there's been a high, I would say, hype over the long-read sequencing. So long-read sequencing is what we call the third generation sequencing. And what's going to happen next? I think every year it's just changing even faster. So just to give you a quick presentation. So this is how we look at the Sanger sequencing, which we call also the gold standard. This is looking at a gene by gene, exon by exon. It's very time consuming. It's mainly manual and it's expensive because you look at just one part at a time. So this gold standard still is used in clinical setting, but most likely for confirmation or to look at variants that we know are have been discovered in the family, and we want to look at carrier testing and or pre-implantation testing, basically. So next generation sequencing is what's been used for creating the reference genome. So we see from the first draft of the genome a steady decline in the cost, especially around 2008 because of new sequencer being on the market and new technology. So there's definitely a decrease in cost and time. And then, but it took still almost 10 years for the implementation of NGS within a clinical setting. And you can see now that the sequencing cost is not keeping decreasing. And this is mainly due to the fact that the technology changes so fast that actually you need to upgrade your pipeline, your computer, your bioinformatics, your sequencer so often that the overall cost is not going to keep decreasing. So what are the remaining challenges? Why do we want to use long-read sequencing? So one of it, long-read sequencing, is that in many cases, having only the program that is affected or having just one of the parent decrease our ability to find a diagnosis. But using the long-read sequencing, we can reconstruct haplotype and we can phase variant, which increase the diagnosis. It is important to tell also that it's about 50% of our diagnostic are actually de novo events. So I think the parent is essential to prove that the variant that we are detecting is absent in the parent DNA. The other thing of long-read sequencing is we know with the short-read sequencing, there's a false negative rate due to the imperfect coverage. There's also regions that are very difficult to sequence, such as repetitive region, pseudogene, and actually if we think about those pseudogene, there's about 10 leukodystrophy genes that are known to be affected by such, and that include some common form of leukodystrophy, such as ABCD1, TEP4, and GBA. And the long read allow expansion disorders and structural variant detection as well. So what is long-read sequencing? So since our partnership with PacBio, we have done over 200 genome at 30x using the i5 SQL2 system. We first we were focusing on our negative cases that had both exome and genome analysis. And comparing the technology, which is still under active development, we work closely with PacBio to be able to do an automation of the sample preparation, isolation, and the libraries. So what's the difference? So when we look at long-read sequencing, we are talking about 15,000, 20,000 base pair. When we look at short-read sequencing, it's 150 base pair. So it's a huge difference in terms of the size of the fragment that you are sequencing. So one bias of the long-read sequencing is that it does have a higher error rate than the short sequencing, but the most one thing to keep in mind is also the cost. It's 5 to 10 times more than genome sequencing, and you have the compute time. So I'm gonna here show you like some challenges cases that we resolve using the long-read sequencing, which are not pure leukodystrophy, but do have some overlapping features. So this family was actually seen for intellectual disability, lissencephaly, and some other EEG abnormality and seizure. So even using a deep coverage in genome sequencing, we miss a de novo variant in a gene called CEP84L that we see beautifully using the long-read sequencing. So even with genome sequencing, there's still a region of the genome that we cannot have a perfect coverage. And that was the perfect diagnosis for this family. Another challenges is actually pseudogene that we resolve with the long-read sequencing. So this particular case is at a long diagnostic odyssey. So we finally, she's 12 years old now, actually, and we finally have a diagnosis for her. So it was a family that was enrolled for the Illumina, the NIH and the NOS program. She had negative panel, exome, and genome sequencing. So we enrolled this family in our program, and we did PacBio Hi-Fi, and you can see that there's a de novo. It's a recurrent mutation in TOP2A, which is known to have a pseudogene. So even though we have beautiful coverage looking at the NGS data in exome and genome, the fact that this region has a pseudogene, some of the reads map to different regions, not just to the specific gene, which give us a false negative result because the reads that were having this mutation were mapping to other regions. So we didn't have a good resolution of the detection of the specific variant. Another challenge that we resolve actually with the long-read sequencing is the haplotyping and phasing. So even in cases that we do not have the parental sample or both sample, we can reconstruct the haplotype and phase the variant. In this particular example, actually, the family already knew the mutation in their child. It's a recurrent mutation in KIF1A, which causes neurodegenerative disorders. But the family was hoping to use an experimental medicine, and to do so for the construction of those, the technique, you need to have the entire haplotype of the region. So doing the haplotyping of the region, we confirm that the mutation arose from the paternal chromosome in that particular child, which is not significant for the treatment, but it's significant to design the oligonucleotide. So what else that we can do with that? Not only in that particular cases, the first idea was to work with Anne Lorraine Foundation that to see if they were able to design antisense oligonucleotide to maybe use this as a therapeutic treatment, well, to help stopping and slowing down the regression in that child. But also we can use this information and look at other variants in KIF1A or in KIF1A partners or in gene that could actually, she has like refractory seizures. So we can look at gene that might give us like idea of which seizure treatment to use or not to use in that particular child. So we can use those long read for additional information. So now I'm going to present you a couple examples.
Isabella, sorry, we're a bit over time. Do you think you could this will probably be the most interesting part. So let's try to go
yes, I'll do it fast. Okay. So we have only 3 cases to present. So this case was known to have a polar 3A mutation, but missing the second allele. And this family had 2 affected individuals. And using exome sequencing and Sanger sequencing, we couldn't find the second allele. So we did whole genome sequencing using short reads, and you can see beautifully this maternally inherited deletion of exons 6 to 8. And this is the black marks. And this particular variant was actually reported also in an unrelated family in 2020. So we confirmed the diagnosis with that family. Another example is actually this family, which has been like followed for many, many years, which has delayed myelination and developmental delay. And using our artificial intelligence software, so we found this de novo loss of function variant in a gene called DAGLA. And this gene has not been associated with human disease, but the mouse model do have defect in myelination, give it a very good candidate. And also this gene is part of a family of genes which has been associated with some similar phenotypes. And then we submitted to GeneMatcher tools to try to find additional families with mutation in that gene. And actually, there were 25 entries, and we just submitted a publication this month for this novel gene. Another cases that I want to show you is this particular cases that presented with leukodystrophy plus some brain anomalies, dysmorphic features, and for which actually the artificial intelligence highlight 3 different candidate genes in that particular cases. So the first one is also a de novo submutation in a gene that has not been associated with disease, but the mouse model do have some overlapping features. And more importantly, a gene within the same family caused a disease that have very beautiful overlapping features with our patient, giving it a very good candidate. And then again, we submitted to GeneMatcher. This gene has only 3 variants reported in the human mutation database. But since the gene is intolerant for loss of function, it's definitely a high candidate in our list. But when you have cases that do have more complex clinical presentation, it is not uncommon to have a dual or triple diagnosis. And this particular family has also a de novo missense variant in a gene called KDM1A, which has a very beautiful overlap in terms of the phenotypes, which is absent in population database, but for which, because we're using genome, we have a lower coverage in some of the region, it's going to require Sanger confirmation. This gene is associated with autosomal dominant neurodevelopmental disorders with some dysmorphic features. And lastly, this family has another de novo variant, which is a glycine in a gene that doesn't fit well the clinical presentation. However, if you dig a little bit more in the literature, you see that not only this gene has been associated with Ehlers-Danlos syndrome as an autosomal dominant form, but there's also an autosomal recessive form of the disease that is associated with polymicrogyria with or without the Ehlers-Danlos phenotype. So we cannot exclude that maybe we are missing a second allele in that gene that could be the recessive form of the disease. So the more we sequence, the more we realize that even known disease gene might have a different mode of inheritance and a very different clinical presentation. So what's going on? So we definitely want to increase our diagnostic rate in leukodystrophy. We want to increase also the racial ethnicity diversification and help with overlaying those different technology together to understand better the impact of the mutation and work with other labs, company, and foundation for treatment, disease modeling, and genetic modifier. Thank you so much. I'm sorry. I tried to do it fast.
Thank you.
So thank you for...
That was very exciting. Well, I think in the interest of time, we'll probably have to move on. There is a question in the chat, so maybe you could answer that in the chat.
Perfect.
And then if you stop sharing your screen, I will actually begin to share, and I'll be the next speaker. This will be a talk on Pelizaeus-Merzbacher disease. I think I'm also going to try to weave in some themes that you'll hear in the upcoming talks from Nicole and Vivi. And let me know if you can see the screen. I think I do want to start by echoing the sentiments of Florian Eichler and the Scientific Advisory Board and our solidarity with patients with leukodystrophy that are suffering in Ukraine and the region. Today, I will talk about the advanced diagnosis, functional genomics, and new treatments for PMD. And here are some disclosures. For the neural stem cell study that I'll talk about, I was an unpaid consultant. So when we think about PMD, we're interested in communication highways of the brain, and normally there's efficient conduction of the nervous impulse, but it's enabled by myelin. And myelin is made by oligodendrocytes, and you see it here depicted as these sort of little white blobs over the axon. And without the myelin, you get inefficient nervous conduction and severe disorders. We can track myelin non-invasively in the brain using MRI, and this image is a pseudo-colored image of a diffusion tensor image, just to sort of show the complexity of pathways going through the brain, and this would be this would be enabled by myelin. And of course, the problem with Pelizaeus-Merzbacher disease is the lack of myelin diffusely throughout the brain. Parents may say their child is trapped in a brain without myelin. They can see the personality. You can look in their eyes. They can't talk. They can't sit up. And unfortunately, death occurs usually in the second decade despite medical treatment. And this is a disease due to a mutation of a gene called PLP1, which is a myelin protein. This cartoon shows where some very severe mutations, point mutations, can occur that can result in the early or conatal form of PMD. And this is the disease of oligodendrocytes. You see this also on MRI. These are 2-year-old images of a child who is normal. And in this particular image, the MRI is showing myelin tracts in the sort of charcoal color. And you can see how that's very different in the child who's 2 years old with PMD. There's really no sign of myelin here on this MRI. So what's new, and I think this will dovetail nicely with what Isabel just told you, is we're going to start to detect patients with PMD much earlier because of the need to use MRI in the past. The diagnostic odyssey has often meant that children with PMD would not be diagnosed until they were 2 or 4 years of age. Now, increasingly with the use of genome sequencing and other genetic approaches, we'll be diagnosing them much earlier. And the UK has adopted whole genome sequencing in the National Health Service. And Cambridge has a lot of history in this area. And we use this in Cambridge routinely in the neonatal and the pediatric ICU when we have a child who's admitted. And here's an example of a patient that we took care of with who was admitted at 8 months of age, was floppy and showed some neurological signs, had a kind of sign called nystagmus, where the eyeballs actually start to rotate around. It's a very unusual thing, but we do see that in PMD children. Difficulty breathing and a normal MRI. And that's because you don't really see the differences in the MRI with PMD necessarily so early. It often takes a little bit more time to show up on MRI. But because we have whole genome sequencing, we did exactly what Isabel told you in the last talk. We did the whole genome of the mom, the dad, and the proband. And what this indicated was a deletion of the PLP gene in the baby, and that was inherited by the mom. So mom now is a carrier. We can diagnose the mom. We can pass on that information also for pregnancy counseling, and we can make a diagnosis of a inherited PLP mutation and diagnosis of PMD. Now, this would be, again, an example of a patient who's a little bit earlier diagnosed than we've been used to. And so if new therapies became available, we'd like to start them as soon as possible. So what are these therapies? We really don't have specific therapies for PMD. So we have to think about new approaches like, can we replace or repair the oligodendrocyte that's defective in PMD? And then we can measure the outcomes using clinical parameters and also by MRI. And I want to cover in this talk 3 potential ways forward. We could fix the mutant PLP gene. We could find a drug that helps the oligodendrocytes work better, or we could replace defective oligodendrocytes using stem cell transplants like neural stem cells. And I'll start here. Now, what is a neural stem cell? This is a cell that can self-renew, meaning it sort of gets you can get expanded population, but importantly, it can make the basic lineages of the brain, the neurons, the astrocytes, and for PMD, it can make oligodendrocytes. So what if we transplanted these neural stem cells into the brain of a child with PMD? And this was the subject of a clinical study at UCSF that started in 2010, in which these human stem cells were injected directly into the white matter of 4 children with PMD. And you could see it went into 4 different spots. And then we could follow these spots where the cells were injected by MRI. And we could compare the areas that were injected, let's say this little red box, with an area that was not injected. And by comparing those 2, we could look for signs of myelination, at least as you would detect by MRI. And what this shows is that in the first year after the transplant was done, we would see an increase in some of the characteristics by MRI that you would associate with myelination. One is called fractional anisotropy. The other is called radiodiffusivity. This going down is also something we would associate with MRI. So that was encouraging that there may have been some engraftment and some donor myelin conferred by the cells. Now, we continue to follow these children for 5 years, and at 4 years, we found in 2 of the 4 boys. In this case, there'll be little white dots that are highlighted by the arrows. And these regions also had the biophysical characteristics of myelin that suggested that, engraftment could be long-term. So, as I said, we followed these children for 5 years. What we found was that the delivery and the immunosuppression that we used and the neural stem cells had a good safety profile. 2 of the 4 boys developed antibodies, we think, against the stem cells, and that may account for why we didn't see those white blots in their MRI. And because we saw these findings in 2 of the boys, as long as 4 years, that suggested the cells really had engrafted and may have been providing myelin. Now, we didn't have the pathological data, so we didn't have the post-mortem brain sample to be able to identify whether myelin was actually being conferred, and that's one of the limitations of the study. And it was not a study designed to show benefit. It was a very small study to show safety. We would normally go on to a phase 2 study, but the company that made the cells went bankrupt at that point. So at this point, then the families came to us and they said, well, what more can you do? And so we used an approach called patient-specific induced pluripotent stem cell modeling. And that will get into this idea of, can we find a drug that helps a PMD cell to work better? Now, Vivi Heine will tell you more about this in her talk, but the basic idea of induced pluripotent stem cells is that we can take cells from the child who may be affected by PMD. They could come from the skin, for example. We reprogram them into so-called induced pluripotent stem cells. They're very much like those neural stem cells that I showed you, but they can actually do even more. They can make heart cells or brain cells. The other thing that we can do is we can also correct the gene mutation in the culture dish. So now we can compare what is the effect of a mutant cell versus the effect of one that has had gene correction. It's the same cell coming from the same child, but in this case, we fixed the PMD in this culture dish. Then we can make them into oligodendrocytes and we can study them in the culture dish and then maybe even screen for drugs that would help those cells work better. And so that's the process that you would use for this sort of patient modeling. So what did we find? Well, what this cartoon shows is that, there's a developmental program when we start from the induced pluripotent stem cell all the way to the fully differentiated myelinating oligodendrocyte. But the problem was the PMD oligodendrocytes didn't make it that far. They would die at a pre-myelinating stage. And when we looked at the sort of factors that were being expressed at that stage, we saw a lot of toxic reactive oxygen species, and that's known to cause cell death. It's also associated with iron, and we did screen for different possible ways that this reactive oxygen species were being turned on, and did land on the rationale that it was, in fact, an iron overload syndrome occurring in these cells. But that was also positive because we could then think about therapies, because there are ways to reduce iron using drugs called chelators. So let me just show you a couple of the results we have from the cell culture dish. So here's one of those PMD mutant oligodendrocytes. It's expressing a marker called O4, which is typical of the oligodendrocyte lineage, those cells just before they start myelinating. And so you can identify them, but they're very different than the gene-corrected sister cells. See how nice and bushy they are with these multiple processes. And that's a healthy cell that is surviving in cell culture. These cells are very different. They're very small and they don't look very healthy. And in fact, these cells are about to die. So these cells do not survive in culture. But then look what happens if we add iron chelators. Now, this cell is almost indistinguishable from that cell. And in fact, these cells do survive long-term just with the treatment with chelator. So it was a very positive way forward to think that chelators could be helpful. There is, in fact, a brain-penetrant iron chelator called deferoprone, which has been used in children and has a relatively good safety profile. And so let me sum up this part one to say that I've shown you about the safety of neural stem cell transplant for severe PMD at 1 and 5 years. I've said that the PMD oligodendrocytes with the PLP point mutation, but we also check duplication, are rescued by either gene correction or these iron chelators. And about deferoprone, which is one that we would choose potentially to look at for some PMD patients. And this is a clinical trial that Nicole Wolf is planning, and she may tell you about in the next talk. So now for the third topic, can we fix the mutant PLP gene? Well, there is some promising new approaches being developed for PMD And these use antisense oligonucleotides. Now, what does an antisense oligonucleotide, if I can even say it, what does it? What do they do? Well, we know that the DNA is the blueprint for the production of RNAs, which then become made into proteins. But in the case of a disease like PMD, the protein is a very toxic protein. I've shown you how it causes the death of the oligodendrocytes. So the disease-associated protein is something you want to prevent in PMD to try to reduce the disease phenotype. And that's what antisense oligonucleotides do. They take that mRNA stage, they bind them with a sort of a glue, if you will, that prevents that mRNA from being made into protein. So we prevent or reduce the amount of disease-associated protein made, and that might be resulting in better outcomes. Now, there's a very severe mouse model of PMD, which is called the Gympie mouse model. And I'll just show you this panel B, where this is a survival curve. And the Gympie mouse that's untreated in red dies very soon after birth, like about 3 weeks is their lifespan. But then when they were treated with the antisense oligonucleotides, again, these are mice, these are not patients. And this was all done, of course, in the lab. They had very good survival. So this was work from Paul Tazar at Case Western Reserve University in Cleveland, Ohio, and would suggest antisense oligonucleotides are a very promising way forward. And that's an example of a gene therapy that we hope will make its way to the clinic. So I've tried to give you a little taste, of the future and the new treatments for PMD, and also how early detection will be helpful, because we'll use these genome sequencing approaches and diagnose patients earlier, and that could be helpful because maybe the earlier we start the treatment, the better the outcome will be. I've told you about the safety and the MRI findings of the neural stem cell transplant study that we did at UCSF, which suggests that these cell-based therapies could actually be considered for PMD, and that the oligodendrocytes that carry PLP mutations or duplications can be rescued either by gene correction or by iron chelation with deferoprone. And again, you may hear some more about that from Nicole. And finally, an example of a gene therapy, which is the antisense oligonucleotides for PMD treatment. And so with that, I am going to just say thanks very much to the families and to ELA for support. And I will now stop sharing my screen. And I think probably in the interest of time, I'll carry on to the next talk, which will be by Nicole Wolf. And Nicole is going to do a double act. So she's going to tell us a bit more about PMD and also a 4-H disease. And Nicole from VU Medical Center in Amsterdam. Thanks very much, Nicole.
Thank you so much, David. And thank you all for participating on a sunny Saturday afternoon. My disclosures, no conflicts of interest with this talk. And I'm a member of the Amsterdam Leukodystrophy Center, which was founded by Mayo van der Knaap. And I just would like to tell you what we do in Amsterdam regarding leukodystrophies. We were very focused on MRI analysis, definition of new leukodystrophies, and identification of the causal genes. That's for most patients done. So now we focus more on natural history studies for several leukodystrophies, look at histopathology and cell models for leukodystrophies to understand disease mechanisms, and start also to set up own therapeutic trials and participate in multi-center treatment trials for leukodystrophy. So it's a very exciting time for child neurology and leukodystrophy researchers because things have finally started to move. We care for patients with all leukodystrophies in our center, but we have some research foci. Mayo van der Knaap works on vanishing white matter, MLC, Alexander disease, and we'll talk tomorrow. Mark Engelin is working on XLD, AMN, and other peroxisomal leukodystrophies. He will also talk tomorrow. And my focus are hypomyelinating leukodystrophies, the topic of the talk today, and metachromatic leukodystrophy. And that's a part of our group. And you see also there are lots of young researchers, all working on moving the leukodystrophy field forward. So David already mentioned the myelination, and you see that a term-born baby has not so much myelin. Myelin is pictured here in black, but you see that at the age of about 2 years, the brain is more or less fully myelinated. And that was something researchers found out more than 100 years ago. And what is myelin? It's produced by oligodendrocytes. It's membrane wrappings around a nerve fiber. And there are many sheaths of those wrappings, which consist mostly of fat and of some proteins. And those myelin wrappings actually protect the axons, the various thin and long nerve fibers going through the white matter. So white matter consists of a lot of myelin, consists of those nerve fibers, but also of some other cell types and of course small blood vessels. Now the normal process of myelination is going on from the pregnancy until the age of about 2 years, and those oligodendrocytes mature and then start to myelin those axons, those small nerve fibers. And that's a process which is actually quite quick from the oligodendrocyte to myelinating oligodendrocyte. It takes only some hours, and there is a huge growth of this cell to make those large amounts of wrappings which protect and nourish the nerve fiber. And it's very important to remember that you need a normal nerve fiber to induce myelination, and those oligodendrocytes also provide energy to the nerve fibers. Nowadays, we can follow the process of myelination beautifully with the MRI, and you see how it changes from the age of a newborn to a child of 2 years old. And if you have a lack of myelin, significant and permanent lack of myelin, you call that hypomyelination or hypomyelinating leukodystrophy. And the MRI of a child with hypomyelination looks very much like the MRI of a neonate. And Dr. Roig already mentioned in his talk that at that age, it's really difficult to find out that a child has hypomyelination because a normal neonate also doesn't have much myelin. So often you need to repeat the MRI if you are not sure about it in those young children. And myelin is needed for a fast impulse conduction, but also for protection of the nerve fibers and the nourishment of those nerve fibers. And that's also very important. Pelletier-Merzbacher, and I will talk a little bit more about it, is actually the longest and best known hypomyelinating leukodystrophy. It was first described more than 100 years ago, about I think 140 years ago almost. And the typical clinical presentation we always thought all children with hypomyelination had is this nystagmus, those wobbly eyes, wheelchair dependency, a mixed movement disorder with a spasticity and some extra movements, balance problems, cognitive symptoms, which are usually less severe than the motor impairment is, and what was always thought, and some patients of mine still hear it at diagnosis, life expectancy was thought to be very much reduced. That's actually of one of the first Pelletier-Merzbacher patients, a pathology specimen described in 1915. And it looks very much like what we see nowadays on MRI. And this PLP protein, which is defect in Pelletier-Merzbacher disease, is really the very, very important protein of this myelin sheath. so those were the very first descriptions of Pelletier-Schmerzbacher disease. So you see how long it was ago. The clinical presentation, there are some things we are still learning. For example, that many of those boys have some autistiform symptoms. And I think most of my Pelletier-Schmerzbacher patients always come with a little music in the iPhone of their parents or in a little music box. They like music very much. There is actually in almost all children a little bit of developmental progress in the first years, and how much depends on whether you have a milder or more severe form. Then you have a stable phase of several years, and at some point children start to go downhill again. That means spasticity gets worse, swallowing function gets worse, they get contractures or scoliosis, and life expectancy is difficult to predict. I have patients aged more than 40 years old with classical Pelletier-Schmerzbacher disease. There is a clinical spectrum. You have the very severe forms where patients already are presenting just after birth with breathing problems. And we have very mild forms where children have a mild spasticity, but not much more. And which form of Pelletier-Schmerzbacher you have is greatly determined by the genetic variant you have. The myelin in the peripheral nerves can also be affected, but that's exceptional and only with very specific genetic variants to be found. When we look at the MRIs of those children with Pelletier-Schmerzbacher disease and the different forms, we see that the milder the presentation is, the more myelin you have on the MRI. There is still not normal amount of myelin, but this patient with almost no myelin has a very severe form, and that patient has a much milder form. He's able to walk without support and also to climb stairs. So that's something important. So if we would manage to get more myelin in the brain, we would expect actually to improve the clinics of those patients. I'm not sure whether it's as simple as that, but to begin with, it's, I think, a very good hypothesis. I mentioned already the slow deterioration, and we think that that has to do with the fact that those axons are left unprotected in some parts or very badly protected. And what I mentioned earlier, the provision of nutrients to the axon is also not working well when you have no or not well-functioning myelin. So the axons, which are very long, very thin and very fragile, at some point without myelin or with not good myelin start to die. And that's, we think, what's causing the deterioration we see in those children. So there are more hypomyelinating leukodystrophies than Pelletier-Schmerzbacher disease. When I started my training more than 20 years ago, we actually expected that our many unsolved patients with disorders looking like Pelletier-Schmerzbacher or very much like Pelletier-Schmerzbacher disease, we would find other mutations in other structural myelin genes which are part of this myelin sheath, or perhaps mutations in genes which are important for oligodendrocyte function and differentiation. And we had some mouse models for several of these genes. So there were a group sequencing large patient cohorts for candidate genes of myelin, but without much success. About 10 years ago, half of our patients with hypomyelination were still without diagnosis. And thanks to the new genetic techniques you heard about by Dr. Tifo, for example, whole exome or now whole genome sequencing, the undiagnosed proportion has become much, much smaller. And some of those patients didn't even had whole exome sequencing because the parents didn't want it. The number of known genes for hypomyelination has increased, and we know some more now. And you see that Pelletier-Merzbacher disease and 4H leukodystrophy, I will say a little bit more about it later, are the two most frequent hypomyelinating leukodystrophies. And what was quite surprising, we didn't find so much structural myelin proteins being important for hypomyelination in patients. We found very, very different kind of proteins and a lot of proteins which were important in producing proteins within the cell. And that was a bit unexpected for us. And we still don't understand well why this happens. One reason might be because the cell needs to increase its surface by a really huge factor, almost 7,000-fold in several hours. The cell needs to make a lot of protein. So the protein production industry within the cell, within the oligodendrocyte, needs really to work at a high pace. And that might be why those genes encoding proteins involved in that process are so frequently affected in hypomyelination. There are some structural genes, proteins, which sit within the axon actually, but also those proteins, the same proteins can be present in oligodendrocytes and in the myelin sheath. And the other part, I already emphasized that, are the proteins involved in protein synthesis or MRI synthesis. So those are really quite a number of different genes involved in hypomyelination. How do hypomyelinating disorders other than Pelletier-Merzbacher disease present clinically? Some look really very much like Pelletier-Merzbacher disease. So we used to call those hypomyelinating leukodystrophies also Pelletier-Merzbacher-like disease. But we learned that despite very similar looking MRIs, patients could look very, very different. We had the children who were not able to sit without support. We had children who were able to walk with support, children who had almost no abnormalities when walking. And even I have a couple of patients, when I look at them in my consultation, they don't show any abnormalities. And that, in spite of having the same MRI with really, really not much myelin. And why that is, we haven't understood yet. What also most children or adults with hypomyelination eventually develop is some deterioration. It can be very dramatic. Children who have been almost normal can deteriorate to a point that they are no longer have head control and have a greatly reduced life expectancy. But other patients are more stable. And as I mentioned, we think that this is because the axon is left unprotected and undernourished by the lack of myelin. So what did we learn from the clinical side? Patients do not only have severe handicap, but we can see also patients with very mild presentations. And I have even patients who have been diagnosed only in adulthood and sometimes even by chance because the MRI brain was made because of headache. But almost all patients show late and slow deterioration despite unchanged white matter signal, and the brain MRI shows a slowly progressive volume loss of the brain. We call that atrophy, and we think that comes because of the secondary damage of the nerve fibers. And I think that's really important for also later on treatment approaches. So you saw already that hypomyelinating leukodystrophies are very heterogeneous disorders. And you see Pelletier-Schmerzbacher disease and 4H. And when we look only at Dutch patients, Pelletier-Schmerzbacher disease is the most frequent hypomyelinating leukodystrophy. But you see that there are very, very rare disorders. And 4H leukodystrophy is actually the second most frequent hypomyelinating leukodystrophy. This leukodystrophy is caused by recessive variants in genes encoding subunits of RNA polymerase III gene, which is important for, in the end, protein synthesis. And the 4H stand for hypomyelination, so the lack of myelin, hypodontia, which means too little teeth, and hypogonadotropic hypogonadism, which is a long word or two long words to say that puberty development is absent or very, very slow and incomplete. And the children have a hypomyelination, but they also have a loss of volume of the cerebellum, which we can also see on the MRI. And additional frequent symptoms are myopia, so short-sightedness, and that can be very severe. And children often have problems growing. There is also a broad spectrum of severity, and we think that depends on mutations in the gene, but we haven't understood well why some children are mildly and others severely affected. And what I already mentioned, we also see that deterioration. When we look at the MRI only of patients with 4H, so not comparing this with Pelletier-Schmerzbacher or other hypomyelinating leukodystrophies, we see actually again what we learned from Pelletier-Schmerzbacher disease, that if you have less myelin, you have a more severe clinical presentation. And also if you have a more volume loss, you see a more severe clinical presentation. So the MRI does help us in connecting the clinical severity to the lack of myelin. And what we learned in the last 3 or 4 years, that there are also other disorders, or not other, we can even say other disorders. We have some children who look exactly like 4H patients or all the other 4H patients I know, but they have actually more or less normal myelination. They do have the cerebellar atrophy, but otherwise they are like a typical 4H patient. And I don't understand that, to be honest. Then we have patients who have only spasticity and very typical MRI, especially patients with polar 3A variants, also with a normal myelin, but with abnormal myelin in the tracts which control motor function. Then we have a disease, we see an almost normal or even normal myelin, but the deep structures, neuronal structures in the brain are very small and have an abnormal signal on the MRI. And there we have a very specific genetic variance. And then we just learned that there can also be a prenatal onset with the cardiac involvement, so with heart involvement. and also a brain malformation of the brain cortex here at the outside of the brain. So for age is not only a white matter disorder, and you can have involvement of the cortical neurons and of the deep neuronal structures in the brain. There's also another disease which is not that rare. It's also actually in the first patients, we thought it's a typical Pelletier-Merzbacher-like disease with hypomyelination, and we found variants in this gene RAS1. And when we looked some years later, we had collected about 20 patients, and we saw that the clinical spectrum was much, much broader. We had very mildly affected children with mild spasticity, mild cognitive impairment, and an almost normal or even normal MRI scan. We had then the typical patients we first described, and then we had babies presenting with severe epilepsy from the first days or weeks of life. And those children had either severe volume loss of their brain or even a really abnormal brain structure with abnormal cortex of the brain. Depending on the variant, the variants which sit at the very center of the protein of that affected protein in this disease, they actually lead to those very severe variants. So this is something which gives us pause to think of whether those what we think myelin disorders really only affect myelin or also the nerve cells. And it might be specific for only some disorders. And Pelletier-Merzbacher disease, for example, might be an exception, and only oligodendrocytes are affected. But I think it's something we can't discard, and we need really to also look at neurons in those leukodystrophies. Now, treatments. Dr. Rorich already mentioned the first trial for Pelletier-Merzbacher disease using those stem cell injections, and that has not been followed through. He also mentioned the iron chelators because of the findings in patient cell models of Pelletier-Merzbacher disease. And those iron chelators are medications which are used for the treatment of certain blood disorders where children and adults need a lot of blood transfusions. And with those blood disorders, with those transfusions, you get a lot of iron in your body, and the iron is toxic, for example, for the heart and the liver. So you need medicines which scavenge the iron and prevent iron overload in those blood disorders. And those medications are already used in adults and children. Not all are registered for young children under the age of 6. And there are some side effects like nausea, vomiting, diarrhea, which are quite frequent, and leukopenia, that means a lack of white blood cells or even absent white blood cells. And this is giving you a risk of even life-threatening bacterial infections. So it's not nothing, those medications, but we think it's worthwhile to test them. And I hope we can start soon. I said it earlier, but all the COVID situations actually delayed the trial development and start of the trial quite considerably. But what will we do? we will treat patients with Pelizaeus-Merzbacher disease, and I will explain you in the next slide which patients for a duration of a year, 12 months, with defiripone, with this medication, and we look whether the motor function improves. We would like to look at the motor function because that's easy to measure, and that's also important and meaningful for a patient if the motor function improves. We also have secondary outcomes, and the most important one is whether we see improved myelination on the brain MRI. And we will measure that very meticulously, not only with the images I showed you, but also using techniques where we really can measure the amount of myelin. We also look for markers which can help us to in future trials, look at effects of treatments for Pelizaeus-Merzbacher disease, and we do that in CSF and in blood. What does participation mean for a patient? I think the two most invasive tests are the two MRIs at the start and after 12 months, because the MRI will show us about myelin. And then we will also take blood and CSF. We will do a small skin biopsy if there is not already a skin biopsy available of that patient. And the patient needs to have weekly capillary blood tests, and that can be done closer to home. And the patient needs to come 3 monthly to Amsterdam for more detailed blood tests and for examination and video examination and motor function testing. And why doing a study and not just treating patients with Pelizaeus-Merzbacher with this medicine? You would really like to know whether it helps, because it can we can learn from it. Perhaps it doesn't work and doesn't do anything in patients. Perhaps it does a little bit. Perhaps it's really very effective. We don't know yet. But to learn it, you really need a trial. The trial will be small, so we will only be able to see really significant effects. And I think it's not bad, because I think we all would like to give this kind of treatments if there is a real meaningful effect for a patient, and not only a little bit more myelin on the MRI. Which patients will be included? Patients up to the age of 7 years, and the severe forms. Why do we have those criteria? In older patients, we have already the damage of the nerve fibers, and we don't know whether those nerve fibers can be myelinated as well as undamaged nerve fibers. And when nerve fibers are already lost, symptoms are not so likely to improve. So for the trial, we will only include the younger patients. And we will not include the milder patients, because they show anyway a better motor development and more myelin on the MRI. So it will be very difficult to say whether that's a treatment effect or an effect of the normal development in this specific form of Pelizaeus-Merzbacher disease. So I think I have gained some time. What have we learned in the last 10 years? Hypomyelination are many, many different disorders. Genetic causes and disease mechanisms are variable. Severity is very variable, and it depends on the affected gene. It depends also very often on the specific genetic variant in that gene. And sometimes we have no good understanding yet why some patients are so severely affected and others less. For a single disorder, so for 4-H leukodystrophy or for Pelizaeus-Merzbacher disease, the amount of myelin correlates with clinical severity. But that does not hold true when you compare, for example, Pelletier-Schmerzbacher disease with 4H leukodystrophy. Then that doesn't work out. A bit of myelin or abnormal myelin are not good in the long run. So we really have to do our best with the treatment trials to get as normal as possible myelin. And that might be difficult. I hope not. But what we see in the patients, for example, with Pelletier-Schmerzbacher disease, who have a bit more myelin, they are in the beginning really better than the patients without myelin on the MRI. But they also deteriorate and lose what they have achieved. For example, the children who were able to walk often lose that ability and really deteriorate significantly. For some disorders, we have a clear neuronal involvement in the most severe forms, and we see this slow deterioration in most patients with hypomyelination from adolescence, usually as a common mechanism. So treatment approaches have to keep all this in mind. So I would like to thank a lot of people, especially Mario van der Knaap, of course, Mariana Bujani, our neuropathologist, Petra Pauls, who does quantitative MRI imaging, Rezi and Quinton, who do the genetics, Fifi Heine, who will talk next about her research for hypomyelinating leukodystrophy, and PhD students, and the international co-workers, especially Geneviève Bernard from Canada, Inga Harting from Germany, and Adeline van der Ver from the US, and Cass Simons from Australia. And thank you for your patience, patients and families who help us with the research. And of course, happy birthday to ELA, and thanks to ELA for financing a lot of leukodystrophy research.
Thank you very much, Nicole. That was a fascinating talk. And there are a couple of questions in the chat, in the Q&A, which maybe you could answer. And in the interest of time, maybe we will move on to Vivi's talk. So I'd like to invite Vivi Heine to present. So you heard that she's also in Amsterdam as part of the leukodystrophy group there. So Vivi, we're looking forward to your talk.
Thank you for your introduction, David. I think you can hear me well and see my slides. Okay, perfect.
Yes, looks good. Thank you.
So the human-induced pluripotent stem cell technology, David already introduced it. We also call it the iPSC technology. It allows us to generate embryonic stem cell-like cells from adult cells. And we can do that from every individual. We can take a skin biopsy or some blood. And when we put these cells in culture, we can reprogram the cells to these so-called iPSCs. And the iPSCs have the same capabilities as embryonic stem cells, pluripotent stem cells, meaning that they can differentiate into any cell type of our body, including different brain cell types. In recent years, because of improved DNA sequencing tools, and I think Isabel's presentation was a very good overview of how it's evolved over time, many more genetic causes of underlying leukodystrophies have been identified, and that majorly impacted diagnostics. But I think so far it has not really give us more insight into the real disease mechanisms, and also not provided us yet with more effective therapies. The iPSC technology can help here. The iPSC technology is giving us new research tools, especially of interest for the genetic disorders. IPC models have certain advantages. They are human-based, and so on the contrary to many traditional research models, such as mice, they can overcome some issues that many findings in mice cannot always be translated to the patients. With IPCs, we can study how patient cells develop pathology also over time. We can also choose how we can. I hear myself twice, but maybe I need to change the settings. So, so we have the possibility to decide what kind of cell types to create from iPSCs, those cells that we think are of importance to the disease, and importantly, the iPSCs contain the patient genetics. So it allows us to study how the patient genetics is actually influencing the cellular changes and the pathology. iPSC models can not only be instrumental in the studying disease mechanisms. The example also came by that it also gives the possibility to create autologous cells, but also more increasingly, IPC models are being used to set up platforms to see how compounds could actually normalize the cellular phenotype that we see in the IPC models, and that it gives us also new prospects to develop new treatment strategies. And in the end, it might also be very helpful in setting up platforms to hopefully support also diagnostics in better deciding how certain treatments out there are more promising for one candidate and maybe not for another patients. But these applications, they are still in development. IPC models already impacted many research fields. We focus here on generating brain structures from IPCs. We generate IPC-based culture systems to model cell-cell interactions that are present in the brain white matter and to study if and how these are affected in the brains of the patients. The cellular networks in the brain white matter, they are complex. They consist of different cellular structures. Nicole already highlighted it, that we have axons there, we have oligodendrocytes, we have also astrocytes in the white matter. So different cellular structures that all interact very closely, they are dependent on each other, and all together contribute to the integrity of a healthy white matter. So when we are actually studying the leukodystrophies, so it's not only about the oligodendrocyte and the myelin that they are creating, but yeah, we should also consider the other cellular structures, such as the neurons that are already mentioned before by Nicole. The IPC field in the last, let's say, 15 years, they have been optimizing different protocols to generate single cell types, just a culture with just one particular cell type, a kind of a monoculture, you could call it. And that gives us the possibility to study how the genetics of a patient is influencing the development of that particular cell. But also there have been protocols that have been developed to create co-cultures, such as co-cultures of neurons with oligodendrocytes or neurons with astrocytes. They can then be used to see how the genetics of one cell type can influence the other cell type. And in recent years, also the so-called brain organoid cultures, also called spheroids, they have been approved a lot in recent years. Organoids are three-dimensional brain structures in cell culture, and these cultures are spontaneously or more spontaneously developing in different neurons and glia cells together, and in that way it's been considered to mimic better the human brain. However, the brain organoids can also come with a few extra challenges to keep them well. For example, they can take a lot of time and they can be more variable. All these culture systems, to develop them and to find the best protocols to create specific cellular structures and connections, we need to collaborate closely with other researchers who are also developing these protocols and share expertise. So we set up a European consortium of different experts within Europe. Here you can see Dr. Angela Gritti in Italy. She's already for her lab for years already is doing research in the leukodystrophy field, and I think she's also presenting tomorrow. Professor Oliver Brusler in Germany, he's a leading stem cell expert in Europe. Professor Monica Sousa in Porto, she's an expert on studying neuronal functioning using advanced imaging tools. And Dr. Maria Cecilia Angelo, she's in Paris, and she's an expert on myelin biology and studying the functional interactions between neurons and oligodendrocytes. And we're also very happy to have ELA on board because they are giving us advice and input, and they give us the possibility to reach out to families and patients. And by sharing disease-specific knowledge and aligning different cellular protocols, cell culture protocols, different methods, we think we can accelerate our search for new insights and to better understand disease mechanisms in leukodystrophies. So within this consortium, we have discussed the different protocols that are ongoing in the different labs, how we can adjust them, how we can improve them, and how can we decide on, let's say, the best protocol and stick to that to avoid that we gain differences in the results that we are getting just because it's a different lab or the different machines or regions that we are using. And we want to keep it, get it as standard as possible. I'm also happy to show you the faces of the young researchers. They are actually doing the real work. Elisabeth Mangiamelli in Italy, Lisa Kok in the Netherlands, Joanna Rodriguez in Porto, and Giovanna Cirini in Germany, and Doreen Maas in Paris. Like I said, they do the hard work. They're setting up all the patient cultures. They even have to go into the weekends to feed the cells because they're very long culture systems. They're analyzing the cells at different levels. They also meet on monthly basis online to update each other, how the cultures are going. And they also will soon travel more. It's now more possible to join forces in specific labs. And so they can actually do some of the lab work together because it is just very labor intensive. So they can share the work and they can do some specific assays in a certain laboratory. And we hope, of course, that beyond their research training now, we can actually keep them in the leukodystrophy research field. So we plan to set up a stem cell-based research platform that allows us to study neural cell deficits of different leukodystrophies. But to set up this platform, we first decided to focus on 3 leukodystrophies: 4-H syndrome, Canavan's disease, and GLD, global cell leukodystrophy. These leukodystrophies are caused by different genetic changes. It's also thought that different neural cell types are evolved or play a role in the disease pathology, but maybe already in the former talks, it was already mentioned that the strict idea that only oligodendrocytes are involved in white matter damage already changed. So we think because the white matter is consisting of different cellular structures, we also should study these different disorders in parallel, in the sense that we need to study all the different cellular structures like the neurons, the oligodendrocytes, the interactions, to see what is changed in these patients' cells. Are, for example, the neurons first affected, or maybe the astrocytes? Can the defects in one cell be mediated towards another cell type in the white matter? When is it starting during the development? So these are things that we would like to answer with using these model systems. I would like to give you some examples of what we are currently doing. We are now generating neurons from the patient iPSCs. These cultures, these neuronal cultures, are representing cortical neurons. This is a mixture of neurons that project signals so that it has what we call excitatory neurons in there. Those are neurons that project signals to other neurons that are stimulating, but there are also interneurons present in these culture systems, and they are more important to, let's say, fine-tune the network signals. And we want to see to what extent the neurons in the patient cells are different, growing different, functioning different than cultures that we created from control cells. For neurons to function well in a large network, they need the ability to move and to extend the protrusions, make new connections with other cells, and also the kinds and the number of connections that they make with each other, that actually determines how the networks act in total and how active the network is and whether it functions abnormally. So if a cell is, let's say, less happy, these properties are easily affected, and we can find those back. So what we first look at in these neuronal cell cultures is looking at the cellular skeleton. We call it the cytoskeleton. And more specifically, we are looking at the proteins that form this cytoskeleton. We look at the morphology of the cells and also at the cell-cell connections. And here in the bottom, you see an example of the kind of cultures that we are creating. So they are firing, as you can see. Going to the next slides. So here here on the left, I show you how we study those major family of proteins that play an important role in the cytoskeleton. They are called microtubules. We label the microtubules with a fluorescent marker, and then we can measure their dynamics over time. And the cytoskeleton is really important for the dynamics of the cell itself, but the cytoskeleton is also important for the transport of all kinds of vesicles within the cell, including the mitochondria. The mitochondria are the energy factories of the cells. They produce energy by breaking down glucose, amino acids, fatty acids. And on the right side, I will start the movie again. There you can see how the mitochondria are actually moving. Yeah, there it is again. And when actually the cells are unhappy and unhealthy, then the microtubule dynamics and the mitochondria transport is, for example, affected. So this is a way of looking at the cells, the health of the neurons, but there are definitely also other assays to look at. So another characteristics, another example that we look at are the connections that neurons made. Those connections are called synapses. And in chemical synapses, the electrical signal in the sending neuron is going via the axon, and it is transferred via a neurotransmitter. And depending on the kind of neurotransmitter, a certain signal is given to the receiving cell towards the dendrites, and that can either be stimulating or it can also that the receiving cell is being inhibited. And we can visualize these axons and the dendrites, and we can mark the different neurotransmitter and can see whether the architecture of the cell is changed, of the axons of the dendrites, and also whether the total number of synapses or the total number of connections between the cells or specific synapses are changed. And if that is changed, that will affect the whole network. I'll give you here an example of what we did for 4H syndrome, that we created control cultures and 4H cultures. Here the synaptophysin 1 and the VGAT are typical markers for synapses. The MAP2 is a marker for the dendrites. And here we can see that when we were actually counting the VCAT positive synapses and the synaptophysin positive synapses, that specifically the VCAT, which are typically indicating the inhibitory synapses, are decreased in the 4H cultures. So it feels that there is less inhibition in this neuronal network, and that is changing the whole network activity. And next questions are that is it maybe a subset of neurons that is affected? How are this changed neuronal network influencing the oligodendrocytes that are creating the myelin sheaths? Could that be a reason why the myelin is maybe changed in these patients? So this is now giving many more questions that we would like to follow up. Another culture system that I would like to highlight that we are creating within the consortium are the brain organoids. Already mentioned it before, we can make single or monocultures, then you're a little bit more in control. But if we want to create a culture system that is better mimicking the in vivo situation, then the organoid structures are in that sense better. The neurons and the different neurons and glia cells that are developing in our brain, they are dependent on each other, and they are being generated in sequence. So when the glia cells are not maturing properly, then also the neurons cannot develop properly. So if something is changing, that the whole brain organoid might be give a better representation of what is going wrong, let's say, in the patient brain. If we look at brain organoid cultures, or if we compare brain organoid cultures with brain organoids that are made somewhere else in another lab, it's maybe good to realize that they can be quite different. So it's not that we created a whole brain in a cell culture dish. It's either these organoid cultures are more representing more the cortical forebrain structures, or organoids are more representing the midbrain structures or cerebellar structures. So these are representing certain local circuitries and networks that we have in the brain. And here the images show you some examples how such an organoid is developing over time. 60 days is already quite long, but we can actually keep these brain organoids for quite a long time, for even months. We collect them around 3 months, but there are people who are keeping these organoid structures for a year, even for 12 months. You can actually also see the organoid structure. So here in the top right, you can actually see that you can actually see the structures by eye. But if you really want to study the cellular composition and how it is changed, we need to process these organoid structures in such a way that we can create or make thin sections, and that we can study these brain organoids under the microscope. And here I'm also showing you some examples of some markers to visualize the neurons and the glia cells in these organoid structures. And in the bottom, the green cells are also indicating that the oligodendrocytes start to myelinate. And this is a protocol that was first set up in Milan by Elizabeth, and now she's teaching the other young scientists within the consortium, so we can all do the same protocol and then start comparing the control versus the patient organoids that we created. So in this talk, I hope I gave you a little bit of an impression of the work that we are doing within this European consortium, really focused on using iPSC stem cell-based model systems, optimizing different culture systems with the hope to really identify cellular changes to get insight in what is going wrong in the patient's cells. First focus on 4H syndrome, Canavan's disease, and GLD. But hopefully this is a platform that we can also use to study many other leukodystrophies. That is really the hope. And of course, many people contributed to the work already for a very long time. I just want to mention a few. Of course, we would like to thank the patients and the families who are donating the cells, who are actually given the possibility to create the stem cells and to study them. I would like to thank ELA for their support and contribution to this consortium. Nicole Wolf, who is an expert on 4H, but actually an expert on many leukodystrophies, as you saw. And my lab, and especially Lisa Koch and Stephanie Dovis, contributed to the work here. And already mentioned all the consortium members that I listed here, and of course the funding agency that made this possible. Thank you for your attention.
Thank you very much, Vivi. So if I could ask maybe Isabel and Nicole to come back on. I think we can. We have 20 minutes for questions, and I think we'll be able to finish on time. So thanks again to all the speakers for really some very exciting talks. And I think there have been some great questions in the Q&A, which Nicole's been answering in multiple languages, as far as I can tell. And then there's one live question, which I'm going to read out for Nicole to answer. And this reads, how much myelin are we aiming for to help patients with hypomyelination? 50%, 70% or more? Because 100% will be very hard to achieve. So what would be the minimum to expect better quality of life?
Thank you for that question. The honest answer is we don't know yet. I agree that achieving 100% of normally structured myelin is perhaps not what we should aim for at the moment with those first trials. For the very distant future, I think that's still the best. What we also should think about is how could we, even with only 50% or 30% or 70% of myelin, which is perhaps not as good as normal myelin, how could we still enhance axonal health and ensure nutrition of axons, for example, and to prevent secondary axonal loss and deterioration. And in my mind, we should also work on that question because I think that we will need that knowledge too.
Great. Thank you very much, Nicole. There are some hands up. So I was going to ask Esther Bella to maybe turn on your microphone, and if you could ask your question, please. Seems like you might be on mute though, Esther, if you click the little microphone. So if not, maybe while Esther's figuring that out, can we move on to Nadia Carnion for your question, please? I think, Nadia, I can't hear you. Could you speak up now? So unless anyone else is hearing, I'm afraid that feature maybe we'll try one more time. If Hilary Dosh could ask your question, let's see if that.
Hey there, can you hear me?
Yes, if we can. Thank you very much.
Yeah, I was just wondering. It's great to hear I'd like to hear more information on if we've had any findings or preliminary findings from the 4-H studies that we did. That I think Vivi that you were working on. It sounded like there was more questions, but I didn't catch if we had found any more information on the mechanisms of 4-H or any information you could share there would be great. My daughter Cora has polar 3A.
Thank you for that question, Hilary. Yes, we have indeed some more preliminary data on these 4H cultures. So what I showed you is that we see less inhibitory synapses in the neuronal cultures, and what we also did is plated these neurons on cell culture plates that have, let's say, electrodes on the bottom. That gives them the time to measure the electrical activity of this neuronal network over time. And there again, we see that the activity in the neuronal network is different than in the controls, and that's a little bit in line what we also see with the less inhibitory synapses, that there is an increased excitatory activity. So we actually see that the network is what we say is getting faster synchronized. And that's an indication that the network is a little bit more mature normally, or there's some activity not developing properly. So we are looking more into that, whether we can confirm this. And in parallel, we looked at the RNA expression, so the gene expression, whether that is different in other culture systems that we created from the 4H patients. And there, some genes are also changed that are pointing to some neurons that we also have in the cortex, the provalbumin interneurons. And those are, again, interneurons that are really important in fine-tuning our neuronal network. So that could, again, support that, let's say, the inhibition and the fine-tuning of the neuronal network is not developing properly, at least in the cell culture system. And we want to see whether that's also affecting the maturation of the oligodendrocytes and the myelination. So, so sorry that I couldn't present all these results, Hilary.
No worries. No, thank you for going into more detail. Great, thank you.
Okay, thank you very much, Viva. And can we see if Nadia, are you able to ask your question now? It looks like your hand is still up. It should be okay now. Could you try asking the question?
Should I read it?
Please, yeah.
Yeah. The question is about a carrier lady with a PLP1 variant, and she asks about treatment trials aimed at those carrier women, and whether there are treatments, for example, for the fatigue those patients have. There were some other questions about carriers and symptoms in the chat. For Pelizaeus-Merzbacher disease, so we have a little bit of the paradoxical finding that women with mild variants, so leading to relatively mild disease in boys, do develop symptoms, whereas women carrying very severe mutations do not. And there are no trials yet for patients because those women who develop symptoms usually develop gait problems, myspasticity, urinary incontinence. So one poster has said very much like AMN, and that's true. Perhaps a part of it is also the same process, namely axonal degeneration. And I think it's very important to look whether you can treat this myspasticity with spasticity treatment to treat urinary incontinence, and there are medications which can be very effective for carrier women, and that's also what we do. And it's very important also that because I know many women who don't talk about, for example, urinary incontinence. So we doctors need to ask. And if your doctor forgets to ask about it, you really have to tell them, because this is something we can help in many cases.
Great, thank you, Nicole and Nadia. There's a question about how we can preserve axon health, and I think I'm going to take a stab at that one. I want to make the point that myelin is a very important trophic factor to maintain axons. So myelin, is a insulating substance around the axon, but we also know it provides nutrition, and it also helps with the activity of the axon. And so one of the ways to protect axons is to provide myelin. And one of the reasons that we see the degeneration of axons in PMD, for example, would be just the lack of myelin. We see this also in multiple sclerosis, which is another disease of oligodendrocytes where myelin is attacked. Beyond that, there may be ways to help axons to work better if we can modulate their activity, but it's a very good question, and there aren't great drugs probably that are axon protective. There is another question, I think, for Nicole to sort of speak to the side effects. What steps would you take in the trial? Maybe that has to do with the dose of deferoprone you would use to reduce those side effects.
Yeah. Where we need to see whether those side effects are there, and whether they I think, or whether if a child already has problems with vomiting, which we see in patients with leukodystrophies, whether this deteriorates with the experimental treatment. I can't say much more than that at the moment. I think that's with all side effects in a clinical trial. If you have those side effects, you try perhaps with extra medication to improve that. And if that's not working and it's really severe, you need to stop the experimental treatment. Or at least you need to consider stopping it.
And I have a question for Isabel, and this has to do with the maybe the most effective way. If you had a limited resource to apply whole genome sequencing, and I guess this is a two-part question. First, would you rather have a gene agnostic approach, or would you rather have a panel approach? And if you were going to choose how to apply that, would you want to do that as a newborn screen, or would you wait till the patient would come to their doctor maybe with an issue and try to diagnose them right away when they've seen their doctor?
It's a good question. If you have limited resources, which obviously we've been fortunate in our center, I would definitely go with whole exome approach. I think the whole exome are now so well done, and that because I feel like the panel, there's so many novel genes being described every week. I think the panel approach is no more like a go-to. Before, the panel approach was good because you would have a better coverage and you could fix those regions that are more difficult to sequence by putting the effort to make your panel very robust. But the reality is that the technology evolves so fast that no lab, no research capacity can keep up with the novel gene discovery. So I think exome is definitely the goal key. And I think right now with the technology that you can add within your exome sequencing, you can add a backbone for copy number variant. It makes it almost as good as a genome in many, many aspects. As long as you know that the region, some major gene of interest that still have some gap of coverage and you can do a Sanger fill-in for those, I think that would be my go-to. And personally, I think the earliest the diagnostic, the better. And even with, a condition that we do not have a treatment, I think for the family having an answer, it's a huge relief in terms of, also in second pregnancy, their decision making. And I think the therapy is going to evolve fast. There's so many new foundation, new small pharmaceutical companies that have interest in those rare diseases that we should give hope to our family. And without the diagnosis, there's no hope for them to have any tryout or anything.
I agree. So I think there can be many more opportunities for clinical trials based on the diagnosis. And I guess, at the beginning, I think Guy mentioned that there are at least 30 genes for leukodystrophies. Do you predict that will go up?
I think so. And I think just like the last cases, I know I went fast on the last cases, but the last cases where you might have a patient that presents with not this pure form of leukodystrophy, but a more complex presentation. I think we need to open our mind, because the more cases we sequence, the more even the classic disease and genetics are no more classic, because we have like a variable penetrance, we have very variable clinical presentation for most likely due to other genetic variation in our genome. And it's I had my own doubts a couple of years ago, but the more people I sequence and analyze, I think we need to open our mind of dual and triple diagnosis. And we need to make an effort within the same family, like the family with polyartery-A, the two affected individuals, they present very differently. One is, they have the same genotype, but one of them is way much more affected than the other one. Yeah. So we need to look at other reasons. Could be environmental, but when you have two child living within the same, condition and being raised the same, I think we should open our mind to genetic modifier as well.
Yeah. So this raises this question: why with all these genetic approaches, we need to really think about a global community. We need to be able to trade the data and also somehow capture the outcomes, because we're not as good at predicting outcome as we should. So you could have a genetic diagnosis of, let's say, PLP, and it's hard for us to know how severe that child will be. We need to get much better at that. And that will happen, I think, with a more international kind of joined up approach, which for leukodystrophies will be very helpful. I wonder, I noticed, Nicole, there are a couple other questions for you in the chat. Or in the Q&A, did you want to pick one?
Yes, there have been questions about older children participating in a trial. And for the trials, and also I think some future trials, they are aimed at younger patients in the first phase, at least. And that's also the case in other leukodystrophies. For example, the gene therapy trial for metachromatic leukodystrophy was done in the young patients with the severe forms, because in those children you see best whether a treatment works or not, because usually the clinical course in those young children is more stereotyped and faster, so you can see a treatment effect in a reasonable time. And also, those patients in those first trials needed to be not that affected, because if a lot of nerve fibers are already damaged or have been lost due to the disease, you don't get any nerve fiber back with beta myelin. And that's the reason why we do those trials in the young children.
Exactly.
Although I certainly understand why is this frustrating.
Yes. And I'm just looking in the list. I don't see any other hands raised at the moment. And looking at the questions, there is a question from Etiana. And I don't know, Etiana, if you want to come on and answer that. Ask that question live, or if it could be also around that same issue around an older child.
Yeah. There was a question about how do you need repeat MRIs? You don't need repeat MRIs for diagnosis, but it's usually we do repeat MRIs in our patients, depending on the age. In young children, for example, after 2 years, but in older children, perhaps every 5 years. It depends very much on the diagnosis, because we can learn something, for example, about the atrophy, so the loss of brain tissue. And what's also important, that virtually all patients with Pelletier-Merzbacher do develop some myelin in the first years. We have seen that and also analyzed that in a cohort of patients. Also without treatment, you have already some myelin. And we are actually very glad that we did that, because now with treated patients, we have a database of MRIs we can compare the treated patients with, because that's very important to have enough data on the course without treatment in young children, in older children, to be able to better judge the effects of a treatment.
Okay. And I hope, Atiana, that answered your question. I noticed there were a couple of other questions on, availability of deferoprone in other countries, like in France, or for older patients. And my kind of response to that was, I think we should wait for the results of Nicole's study. I think based on that, we would, have more reason to think it could benefit other groups of patients. But we really do need to have a study rather than just sort of going to a drug without enough evidence, because there may be side effects, and we don't want to be over-treating our children if we don't think it's really going to help. So the study is critical to make that kind of advance. We are a little bit over time, but I don't know if you wanted to just, as the final question from Ludovic.
I think the best thing is to talk to Dr. Bösflug about that. I know that she's also busy with analyzing data.
Okay. I think in the, we have finished on time. So again, I really want to thank the speakers for some great talks, Isabel, Nicole, and Vivi. I learned a lot. I hope the families found this very helpful. And can I finally thank ELA for sponsoring the conference? And I wish you all a very pleasant evening. Bye-bye.
Thank you very much. Thank you to our speakers and to our audience. And also, we're changing time this tonight. So for those of you who will join us tomorrow, remember that there'll be an hour difference. Bye-bye. Thank you. Bye-bye.
Thank you all.